And can someone please share the slides? The chair intro. Wonderful. Okay, I'm gonna get us started. In the interest of time, I'd like to welcome everybody to the Heal Pain Strategic Planning Workshop on the intersection of pain and substance use. My name is Joanna Starrels. I'm one of the co-chairs of the subcommittee and of the workshop, along with Dr. Jessica Merlin. Next slide, please. So this meeting is in the context of the Heal Pain Strategic Planning Committee, which is charged with providing scientific guidance on how best to advance pain research through the HEAL initiative by proposing and prioritizing future-looking strategic research priorities for the next 5 or so years. There are 7 subcommittees of the Strategic Planning Committee, and one of which is on the intersection of pain and substance use. And that subcommittee is the one hosting today's workshop. Next slide, please. The background for why we have this subcommittee and also why we have this workshop today is because pain and substance use are so often co-occurring and they complicate each other. And this results in compounded mortality and morbidity and reduced quality of life for people with pain and substance use. So the scope of the subcommittee and the workshop is to understand ways in which pain and substance use intersect and why, to understand the populations that are disproportionately affected by co-occurring pain and substance use, and to develop and test interventions for pain and substance use. On this slide, I show the list of our subcommittee members. I don't have time to name everybody, but they represent a wide swath of expertise at the intersection of pain and substance use. Next slide, please. So how did we develop the content for today's workshop? Our subcommittee members first identified and prioritized the important and timely research topics at this intersection. Then we synthesized these into a list of drafted topic areas, which we then discussed at our workshops, at our meetings with our subcommittee, and prioritized them into topic areas for today's workshop. The topics that didn't get into the workshop are tabled into a dynamic parking lot, and I expect that will also expand through the workshop today. We then identified and invited speakers who are experts on these topic areas. And the presentations and the discussions will focus on really 3 questions. What's the state of the science in this area? What are the most important research gaps? And what are the potential impacts of filling these gaps? And the goal for today then is to elicit and specify these high impact research priorities at the intersection of pain and substance use. So the collapsed version of the agenda is what you see here. For a more detailed version, we'll drop the link in the chat. The first half an hour is introductions and some important framing, including from people with lived experience with pain and substance use. Then we have 4 blocks with both scientific presentations and a 15-minute discussion on 4 topic areas, namely personalized approaches to pain and substance use, equity in highly impacted populations, interventions, and non-opioid substances and pain. We have a 10-minute break in the middle, and we're going to try to keep to the time as much as possible, actually very strictly, so that we can get through everything and have our break. Next slide, please. We definitely want to hear from all of you. So there are 2 ways to interact. The first one is the Q&A function at the bottom of your screen. That's for questions. That's for questions that will be addressed in the discussion section by the presenters and the panels. The chat is for comments things that have not come up that are important, agreeing, disagreeing, or for communicating with our logistics team about any issues. And please do let us know your thoughts. Next slide, please. After today's workshop, we're going to synthesize the content and the discussions and the chat comments to help develop research priorities from the Pain and Substance Use Subcommittee, which will then forward to the full HEAL Strategic Planning Committee. And I want to close by just saying thank you. Thank you for being here. Thank you to all of our speakers and our moderators. And I'm really looking forward to today's workshop.
Thank you, Joanna. Next, we will have introductory remarks about the HEAL Pain Strategic Planning Initiative given by Kathleen Sluka.
All right, great. Well, thank you all for joining. This is a really important topic, and we are in the midst of developing a HEAL Pain strategic plan for the next 5 years. You're here to listen and talk and provide input to the intersection of pain and substance use disorder working group. Both Rob Giroux and myself, Kathleen Sluka, are the co-chairs of this committee, and we're both here at this meeting as well to get your feedback. So before we get started, let's talk a little bit about what the HEAL Initiative is. The NIH HEAL Initiative is aimed to reduce pain and the risk of opioid use disorder by developing safe and effective pain treatments and prevention strategies to improve the quality of life for everybody. And this is the HEAL Initiative is an NIH-wide effort, multiple institutes. As you can see, there's 19 institutes, and we're seeking to speed scientific solutions for the overdose epidemic, for the opioid overdose epidemic.
Kathleen?
Yeah.
Your slides are not sharing if you wanted to share them.
Oh, what? It shows me sharing. Well, let's try that again.
Kathleen.
I can put mine up if you... Oh, you got them now. Here it comes. Except for...
Are they now?
You see your calendar.
Your calendar.
Okay, now you see them?
Yes.
All right, sorry about that. Thank you, Rob.
Yep.
So the HEAL Initiative was launched in 2018 and has funded over 1,800 research projects for over $3 billion. It is, many of these are kind of 5-year projects, so they're just now coming up to the end of the first set of projects. And we're looking now to think about what are the next stages and where are we going next. So we're looking for your input and your support, everybody who is attending here, to recommend research priorities for this HEAL Initiative and to inform the HEAL strategic plan. So this shows you kind of the organization. As you can see, and you've already heard, we have an executive committee with Rob and I as co-chairs, and Michael Falcon is a person with lived experience that sits on that executive committee. We have 7 different groups. Many of these have already had their workshops, but we still have a couple more this week to go. And we're bringing all these together to come up with what we are considering the top strategies to move us to the next level. You can see they're very broad across developing non-addictive pain therapeutics, biomarkers, optimization of interventions to improve pain, some implementation strategies, as well as things that are pretty global, like health equity and pain across the life course, and really thinking about our research workforce and training. And of course, today you're in the intersection of pain and substance use disorder, which is led by Jessica Merlin and Joanna Starrels. So these are our virtual workshops. And as you can see this week, we still have 2 others, the implementation in health services and the health equity and pain across the life course. Feel free to come to those as well. You can register at this QR code and get more information there. These, of course, are all virtual. as you know. So what's happening? Well, in the summer, we asked for input from the community. Right after we formed this committee and started getting our groups together. In November and December, with all that input, we have received, and we put that all together and incorporated those by the subcommittees into proposed priorities. And the groups are here now giving you workshops to kind of go through what they're thinking and where we're going and get your input on refining those. By January, we'll have an executive committee meeting and we'll take all the priorities from all the work groups, refine them and prioritize them and submit them then to the National Institutes of Health. We will do a draft plan and we'll present that to the NINDS Council in February, as well as other NIH advisory councils for their input, and we'll hopefully finalize and publish those by March or April of this year.
At that time. Oh, sorry, go ahead.
What's that?
I just said you're at time.
Oh, great. And so last bit, if you have any thoughts or suggestions on topics at this workshop, you can send them directly to that email below, healquestions@od.nih.gov. And please send your input if you don't get it in today. Thank you.
Thank you, Kathleen. Our next presentation will provide perspective about the lived experience at the intersection of pain and substance use, and will be presented by Katrina Joubert and Michael Falcon. Kathleen, you're still sharing your screen, I believe.
Oh, sorry about that. I
No
can see the calendar.
Awesome. Thank you. Thank you, Jessica. My name is Michael Falcon. As Kathleen said, I'm individual with lived experience that is sitting on the executive council or executive committee. And my overall sort of objective in this position is to kind of give some context and some feedback on I think the overall nature and the overall state of where NIH-funded research is going and how well, perhaps, the integration of the lived experience is being considered in any of its projects related to pain and opioids. A little bit about myself. I'm a licensed occupational therapist. I am an academic. I work at Hawaii Pacific University in the Doctor of Occupational Therapy program. And a majority of my professional work currently is really internationally. So I work and consult and provide feedback with ISP and a whole host of committees and task forces with them. And I've been predominantly working and engaging with them for about 3 or 4 years now. I'm one of the founding members of GAPA, one of our global initiatives for individuals with lived experience and the overall integration of the lived experience into pain research globally. I was grateful for the opportunity to serve in this position with the NIH when first reached out. And I think for this conversation, we felt it was important to add some context about the lived experience, that intersection with substance use. For myself personally, it will be opioids, really to provide some context and sort of anchor the rest of the workshop today. For myself, I have been living with pain for about 2 decades now. My sort of journey began as what was once described as a young 18-year-old. And I was in a near fatal car accident where it sort of left me with surgeries that required the amputation of my left arm. Dealing with that pain was in the acute phase, obviously tremendously difficult, but I would argue that the biggest trauma, the biggest piece was the impact to my overall quality of life. I went from being young, athletic, all the other stereotypical stuff of a typically developing individual, and now I was this heavily debilitated, heavily medicated individual. The subsequent sort of 5 to 6 years of my experience resulted in heavy opioid dependence and then eventual addiction. addiction to the point where I really struggled, sort of maybe realizing or appreciating what was life, what wasn't, eventually contemplating whether or not I wanted to live anymore, a couple times making the decision that I did not want to live. And those are sort of the realities of what lived experience and substance use can look like. Now, on the flip side of that, in retrospect, especially with my clinical perspective, I appreciate that the substance use was not this harmful thing, but rather a mode or a method of facilitating what I was really and truly after, which was maybe a return at the time, a return to a quality of life that wasn't feasible. But now what I realize today, I just wanted a quality of life in general. I just wanted a life that I felt that I could potentially live for. And today I kind of live my life, not so much for things that I live for, but things that I'm willing to die for. I'm a humanitarian at heart, humanitarian in nature. A large majority of the work that I really value is working in low and middle income setting countries, working really hands on the ground, or boots on the ground, hands-on work with a lot of communities. That's really where I find my value. That's really where sort of my quality of life came back to me. And the substance use was sort of this tertiary piece. In the end, had a massive impact on my life, but it did not, I don't know, it didn't qualify sort of everything that I was doing at the time. I am going to stop talking for a second. I'm going to let Katrina go ahead and jump in, introduce herself, and add a little bit different context and perspective as we continue this discussion.
Hi, happy to join everybody this morning. Morning for me, approaching afternoon for others. My name is Katrina Jobert. I am professionally a licensed clinical social worker and a clinical quality supervisor for a large healthcare organization. Personally, I am the family member of somebody who lives in long-term recovery and navigates a daily experience of chronic pain. To share a little bit about kind of my story and my impact and why this matters so much to me, I think it's helpful to share a little bit about my mom's story. I was raised by a single mom who navigated addiction in my early childhood years, and it was through the support of really caring, incredible social service persons, incredible healthcare providers, and really loving family that she found a path to recovery. Fast forward 20 years later, she's decades in long-term recovery from an opioid use disorder. But in the context of her professional work about 20 years ago, she navigated a pretty serious fall and injury in an office setting at work, which resulted in multiple surgeries on her neck, her back, and her shoulders. And today what that means is she navigates a daily experience of chronic pain. We have a strong value system around balancing quality of life as well as professional contributions. And what that looks like today is figuring out how we contribute in both of those settings, both for her and for us as a family. Why this work is so important to me is because the impact of chronic pain and recovery is truly not just a person, but it is a systems-wide experience. So on a very personal level, what that looks like for us is truly daily considerations on how we live our life. As a family, we consider what vehicle we can and will drive if we're going somewhere as a family so that my mom can be physically comfortable. We consider what time of day we plan activities because will she be feeling physically able? Is that a good time of day to participate? We literally think about what furniture we purchase and where we will eat our meals together so that there's a chair where she can be at the table and contributing and being a part of family activities. I will say that the impact of her chronic pain and her lived experience is that there are activities she's able to show up to as a grandparent, and there are activities she's not able to show up to. But there's a lot of time and energy spent in how do we keep her invested and part of the family. In a day-to-day experience, we also think about how we will plan our family schedule. We live in Utah where it snows, and so she strives to be really independent. And if it snows, what that means is as a family, we have to think about going and shoveling her walk. We have to think about what chores and things she will need so that she can continue to live independently. Professionally, what that's meant for me as a family member is actually changing course in my professional journey. 2 years ago, I had the opportunity to pursue a remote work opportunity. And what this means is that I get to work from home and I get to flex my schedule. When I go and support her in medical appointments, I can bring my work computer and I can work while she gets medical care. I share just some of those concrete pieces because I think it's really important to understand this work has such far-reaching impact. And I just feel tremendously grateful for everybody spending time today to continue to invest in pushing the field forward and improving quality of life for the person living with chronic pain, living with an experience of recovery, and all of their loved ones that surround that experience. I also want to just qualify, I'm so grateful for some of the opportunities that I have. It's through my education and through some of my very fortunate experiences that I have the privilege of showing up the way I get to. And I know that's not the experience for everyone. So just thank you for letting me be here today and share a little bit about the impact.
Wonderful. Thank you both. Our next presentation will provide scientific framing and discuss the reciprocal model of pain and substance use, and will be presented by Joseph Dietrich.
Good morning, everybody. It's nice to be here. My name is Joe Dietrich. I'm a professor in the Department of Psychology at Syracuse University. I also direct the Center for Health Behavior Research and Innovation. And as was just discussed, I'm here to present our scientific framing for our workshop today with a focus on the reciprocal model of pain and substance use. I don't have any disclosures to report. So everything that we're talking about so far and we'll talk about today is probably to some degree of interest to everyone here attending the workshop. But when we talk about substance use beyond opioids, it's really important to note that this is an area of interest beyond scientific circles. The national news media continues to pick up on different reports and publications in the space. And this depicts significant interest in relations between pain and substances such as nicotine and tobacco, alcohol, cannabis, benzodiazepines, stimulants, and other substances that are under study. For this presentation today, I did a quick data poll just to give us the most updated information I could. This is not a comprehensive literature search. This is just from PubMed, 1994 to 2023. And what it is publications where pain and these various substances are central to the title. And we've published this data before in a more comprehensive way, which depicts a similar increase over time. If you look at the number of published studies, you can see a real uptick starting around 2009 to 2013. So these are each in 5-year increments or spans. And another thing that's really notable is the 5-year span compared to the previous one saw a 180% increase in publications on pain and cannabis, 82% increase for alcohol, and just about 30% for nicotine and tobacco. And I think this is also part of the reason why we're all here today. So when we talk about chronic pain and substance use, and particularly substance-related disorders, it's important to point out that they're both highly prevalent and commonly comorbid. Now, the exact statistics will vary a bit depending on the type of pain condition, the type of substance being examined, and the setting in which those data are collected. But across those data points, what we also see is significant overlap with other mental and behavioral health challenges. Now, individuals who present with chronic pain and substance-related disorders specifically tend to report more severe pain and greater functional impairment. They also tend to use and misuse opioid medications at a higher rate than people with either condition alone or without. And really central to today's topic is the notion that the study and treatment of the intersection of pain and substance use has been typically and historically siloed, which calls for a much greater need for integrative conceptualization and treatment. To that end, we have described a reciprocal model of pain and substance use, where we find it helpful to break this down into directions of inquiry. So in this case, starting with the effects of substance use on pain. Now, this is some of the earliest work done in the space, which implicated prolonged heavy substance use in the onset of certain chronic pain conditions, with several having unique causal contributions to the onset and worsening of painful conditions. More recently, however, has been a focus on the question, what is the role of pain in the onset of substance use or the escalation of substance use? And a lot of this work focuses on pain as a motivator or proximal antecedent of substance use. So when you put these both together, what you can envision is a positive feedback loop or vicious cycle where pain contributes to substance use maintains or worsens pain, resulting in the maintenance and progression of both conditions over time. So our workshop today on the intersection of pain and substance use is going to touch on a number of topics that are central. We're going to start looking at personalized approaches, including phenotyping and personalized medicine and personalized feedback. We're also going to talk about highly impacted populations, including the role of social determinants of health and mental health comorbidity, with a specific example of older adults. We're also going to talk about interventions, including pharmacologic and non-pharmacologic approaches, and close out with a real focus of substance use beyond opioids, including that which complicates pain and those which might serve a role in pain management. In summary, the translational, transdisciplinary study of interrelations between pain and substance use represents a significant and still emerging area of clinical and empirical interest. And now I'll turn it over to our scientific presentations. Thank you.
Thank you. Our first scientific presentation will be on the topic of phenotyping and personalized medicine, presented by Simone Hartunian.
Hello, everyone. Can you see my screen?
You're good.
Give me 1 second, sorry.
Yeah, just there you go.
All right, hi, everyone. It's really an honor to be part of this panel. So my name is Simone Hartunian, and I'm a clinical researcher in the Department of Anesthesiology at Washington University in St. Louis. In the context of the intersection of pain and substance use disorders, I would like to touch upon phenotyping and personalized pain medicine, and to discuss the need, the status quo, and what we can collectively do to provide better treatment for patients. So because we have a diverse group of participants in this call, let me start with some definitions of what I'm going to discuss today. So I mentioned the word phenotyping, which is characterizing someone's observable properties that are determined by their genes and environmental factors, which could relate to physical appearance, development, or behaviors. So, obviously people are different in their DNA, but it's not only our genes, it's rather the interactions between the genes and environmental exposures, traumas, life events, etc., that are going to determine our phenotypes. So the concept of personalized medicine, or precision medicine, if you will, is really to use this genetic and phenotypic data to tailor the right intervention to the right patient. It could be to diagnose, to predict, to prevent, or to treat various conditions. And now, do we actually need phenotyping and personalized pain medicine approaches for the treatment of pain and substance use disorders? And I would strongly argue that we do. Let's just take a look at two examples. In neuropathic pain, for example, even the best drugs we have work in 1 out of 4 to 8 patients. Now you may say, well, there are some patients for whom these drugs and interventions work. Let's find out who these are so we can prescribe the specific drug, only for those patients and avoid exposure to those who don't need them. Or you could say, well, this sucks and we need more medicines. And because more than half of the patients with neuropathic pain don't get adequate pain relief, even if they're trying 3 or 4 medications. And I'd say probably both of those views are correct. We do need novel drugs, and we need to find out how to best use the drugs we have to benefit the patients on one hand and avoid harms in other patients. And I would say that in opioid use disorder management, sort of the status quo is also less than ideal. Out of every 2 to 3 patients who enter a buprenorphine or methadone-based maintenance program, only 1 is generally able to stay in the maintenance program. And really, we should strive to do better. So I want to give you, oops. Okay. So let me give you just 2 brief studies where phenotyping has been used, either for prognosis or treatment. In this study by Bo Sakavkari and Yornitsky and other colleagues, so patients who had mild traumatic brain injury underwent functional neuroimaging of the brain, and certain measures of functional connectivity between brain regions that are relevant to pain processing were actually predictive of chronic pain development after that traumatic brain injury, meaning that this certain imaging-based phenotype could help us understand what happened in the brains of those patients who end up developing chronic pain, but also may help us predict which patients may need early interventions to prevent pain. Another study I wanted to mention is the study, it's on the right side, by Demand, Finerup and colleagues, of this anti-seizure drug oxcarbazepine in patients with neuropathic pain, where participants were phenotyped with sensory testing before treatment and allocated to 2 phenotypes. One called irritable nociceptor phenotype, when they had preserved thermal threshold but some allodynia, and the non-irritable nociceptor. And in the patients with irritable nociceptor phenotype, the drug outperformed placebo, while in the other phenotype, it did not. So I would say that those kind of studies really require independent validation before having high confidence in implementing them in clinical practice. But these are very promising directions demonstrating a proof of concept for personalized approaches for pain. So in general, in the rest of my talk, I'd like to address 2 conditions where we have an opportunity maybe to characterize this interaction between phenotype and environmental events that can lead to chronic pain development and opioid use. And both are instances where the inciting event is known, and maybe we're able to examine the patients before, during, and soon after the event to better understand what happens at an individual patient level and how this information can help us prevent and treat pain and substance use disorders better. So one is surgery, right? So among patients who undergo surgery, somewhere around 10 to 20% will develop chronic pain related to surgery. Michael Falcon, presented, a very specific experience of his with trauma and amputation. My grandfather had a very similar experience in his early 20s, ending up with amputation and phantom limb pain. And so it is quite prevalent, but not everyone will develop chronic pain, right? So 80 to 90% of patients who are undergoing surgery are going to do fine. And there's a subset that will not. But considering that there are about 300 million surgeries performed globally every year, it's a big issue. And somewhere about 6 to 9% of patients, at least in the US, who undergo surgery are going to start using opioids chronically within a year. The other scenario is cancer chemotherapy, where certain classes of chemotherapy drugs cause nerve damage and neuropathy. And again, not everyone will be affected, but somewhere about 10 to 20% of patients, even after they finish chemotherapy, are going to experience painful chemotherapy-induced peripheral neuropathy. And if someone has cancer and CIPN, they're twice as likely to use opioids compared to someone who has cancer but doesn't have neuropathy. So let me start with the surgery. So my colleagues conducted a small observational study in about 36 patients undergoing knee replacement surgery. The patients had an actigraphy watch, an app-based daily assessment of pain and analgesic use. So this was a few years ago when orthopedic surgeons typically prescribed about 30 days worth of opioids and analgesics at discharge, because recovery after knee replacement is pretty painful for many patients. And thinking that if you give enough, let's give enough medication to everyone, and if they need them, they can take it. It sounds quite a very humane approach. So basically, everyone got about 54 morphine milligram equivalents a day for about a month, and which is roughly about 35 milligram oxycodone a day. And in reality, and you can see on the figure, the opioid use substantially decreased over time on average. And on average, patients use about 28 milligram equivalents of morphine a day. This is resulting in excess prescribing of about 28,000 milligrams of morphine across this tiny little 35 patient population, which is about 3,600 unused pills of oxycodone, right? So you can imagine that nothing good can come out of 3,000 or more pills of oxycodone just laying around unused in people's homes. So this is, I think, an example of an unpersonalized or non-personalized approach. But the reality is that patient trajectories quite differ among each other. Now we have this current ongoing study in about 2,500 patients where we're carefully monitoring pain and analgesic use and other factors daily, about 3 times a day after surgery. And we're also asking about analgesic craving, how badly you feel you need pain medicines a few times a day. And this is just a figure representative of 3 patients who underwent major surgery. And you can see 2 things here. So one thing you can see that the pain level, which are the solid lines, and how much painkillers patients feel they need, which are the dotted lines, are very much aligned per patient. So really, people mostly want painkillers when they're in pain. And I think the second point is that there's a huge difference among individuals, right? So some people having very little pain and little analgesic needs, while other patients are experiencing tremendous pain, and they report that they need a lot of analgesics, right? And we're obviously, as Joe mentioned, are concerned with patients developing both chronic pain and opioid use disorders. My colleague Emma Johnson is finding in her NIDA-supported R03 project that if you have a genetic predisposition or a polygenic risk, either to pain or opioid use disorders, you're more likely to develop the dual diagnosis. However, patients who have lower socioeconomic status and lower educational level are even at higher risk of the dual diagnosis, which again highlights this interaction between the genes and the environment and the need for more comprehensive phenotyping to make sure that we are able to determine patient risk. And I think so a question that my lab grapples quite a bit when someone comes to a surgery is how to best consider all these different variables that come to the surgery. So sort of we launch them on the right trajectory for recovery, considering all the potential landmines. And indeed, there's a myriad of studies that try to identify which factors contribute to risk of developing chronic pain after surgery, and there is a lot. Some are genetic, some are demographic, some behavioral, some related to previous experiences and things that can go wrong after surgery. What we, I think, really understand that this is a multifactorial problem. And I think, and there's a bunch of systematic reviews, just our lab did 4 of them, really trying to sort of summarize what are the factors known for developing chronic pain. And the problem is that there's a lot of differences between populations and surgery types, and it's quite challenging to come up with one formula that can predict, everyone who develops pain after surgery, and also then implement it in an actionable sort of decision-making tool. Maybe one example is a recent paper from Nicholas Pakis, who's a PhD student, who conducted about a prospective study in more than 2,000 European patients undergoing surgery, and came up with this chronic pain prediction tool, which he made available online, that you can go and actually plug in some patient factors related to their preoperative demographics and other things, and get a risk prediction for their chronic pain. It has reasonable predictability, but the challenge is really at the precision at this point, because it's based on a single European cohort and it has not been validated independently yet. And it also considers only simple measures available at bedside and generally is likely not to be sufficient enough to accurately phenotype patients. So many risk prediction models at this point, they point to somewhat similar profile, like high depression, high anxiety, catastrophizing, things like that. And we recently applied a statistical clustering approach to our own cohort of about 700 patients who developed chronic pain after surgery. And it's interesting. So this is only demographic and patient-reported outcomes, even though we have other data. What we find that preoperatively, patients can fall into two distinct clusters. The blue cluster is really the sort of classic view of what high risk for chronic post-surgical pain is, sort of high depression, high anxiety, younger patients, low resilience, etc. However, we can see that there is this red cluster of patients who the prediction models, including Nicholas's model, wouldn't generally predict, but they're still developing chronic pain who are low catastrophizers, low anxiety, higher physical functioning. And we're unlikely to predict those patients just based on those variables we're collecting. So there's really, clearly, there's more to contribute to their risk. And we believe that more in-depth phenotyping, maybe with genomics, proteomics, transcriptomics, will be able to provide more mechanistic insights to characterize those patients and mechanisms that contribute to their pain. And so we're thinking that sort of going forward, really, I think one opportunity is to bring patients, in this context, for example, patients after surgery who develop chronic pain, bring also control patients who didn't develop chronic pain, try to really carefully phenotype and characterize them. And we were fortunate to receive HEAL initiative funding to conduct this sort of study, to try to do really careful peripheral and central phenotyping of patients with post-surgical pain, but also try to develop animal models that can represent the specific clusters or the phenotypes that we identify, so that we can include or facilitate better animal to human translation. Now, all this molecular stuff is good. But one thing that I think we really need to keep in mind is maintaining the patient perspective on all of this and making sure we are patient-centric. Somewhere along the recent impact recommendations, call it with Katie Holzer, Chris Beasley, and others. And this is something that we really try to keep in mind all the time. And I want to briefly go back to our second theme, CIPN, to highlight the importance of patient perspectives when we're thinking about phenotyping and personalized medicine. So in animal models of chemotherapy-induced peripheral neuropathy, the animals develop sensitivity to pinprick. And, if you give them drugs like pregabalin or Lyrica, it gets better. So we said, okay, would pregabalin work better in patients who have more hypersensitivity to pinprick? And we conducted a randomized controlled trial of pregabalin versus placebo, which actually didn't show much difference between the two overall. And then we tested where patients with more hypersensitivity respond better, and we found nothing. So there was absolutely no prediction when we were thinking about the outcomes that patient care, which is like pain intensity, pain severity. With that said, when we assessed sort of the same outcome as in the rodent studies, which is the extent of mechanical sensitivity, actually the results showed that pregabalin worked better on some of those outcomes compared to placebo. Now, the thing is that what patients want, what is important to them, very few patients may say, yes, the fact that my skin is less sensitive is good. But most patients would say, I want to be able to sit through the dinner with my family and without the need to, go and lay down for 30 minutes because I'm in so much pain. And what I care more about is the spontaneous ongoing pain and how much disability it causes, right? And we really need to keep that in mind. And I think it's really a difficult issue for scientists to sort of balance how to dig deeper into the mechanism, yet maintain this patient-centered focus. And there's some examples where really we try to keep the patient-centered outcomes in mind while identifying more specific mechanisms and molecular, contributions, in this case, to chemotherapy-induced peripheral neuropathy. So I see I'm running out of time, so I will basically summarize my talk, and a couple of basically take-home messages are that I think that the one-size-fits-all approach does not work for pain prediction or treatment and really may result in harm and also resource and time waste in patients. Some phenotyping approach in pain has been used, but they've been mostly unimodal with limited applicability so far. There's some progress with phenotyping, but we really need more in-depth multimodal phenotyping, looking at the processes can explain mechanism between phenotypes to be able to come up with real personalized solutions, and just really try to keep patient-centered focus in mind. Thank Thank you for your time. And I want to
Thank you. Our next presentation will be given by Jafar Baksho on personalized feedback approaches.
So, thank you very much, everyone. I am Jafar Bakshay. I'm from Massachusetts General Hospital, assistant professor of psychology. I'm going to talk basically quickly about the personalized feedback approaches as they relate to this basically reciprocal model of pain and substance use, which is a very common comorbid condition, as others mentioned. So, for some reason, okay. So for the overview, the PFIs are basically brief tailored interventions that many are familiar with.
Jafar, can you speak up a little bit? Your audio is a bit low. We're having trouble hearing you.
Let me try to fix it quickly.
The slides are great. We just need your audio to be a little louder.
Is it better now?
Yes, perfect. Thank you.
Okay, sure. I'm going to share it. Okay, my apologies. And so, as I was mentioning, the PFIs are brief tailored interventions, basically the function of delivering feedback for individual behaviors and commonly used in other areas. They're grounded in motivational interviewing and cognitive behavioral principles mainly. So if you want to get a little bit more specifics, they integrate insight from health behavior change theories, such as trans-theoretical models of change and health belief models, with the goal of basically increasing motivation to change. And they have been proven, like in other areas like obesity or gambling, being effective in promoting behavior change. So in terms of the components, personalization, meaning then basically tailoring the health behavior change to the personal or like the individual profile is one of the key components. And next is normative provision of normative feedback, meaning comparing behaviors that the individual is doing to peers or other populations, like in this case, going to be people with similar chronic pain or acute pain conditions and comorbid substance use. And the other components, provision of psychoeducation, informing the patient about the risk and benefits of the decision to continue or not the use of substance. And as it relates to the comorbidity of pain and substance use, basically addressing some of these misconceptions, or kind of, we call it myths, about the reciprocal model of pain and substance use. And you would be sometimes surprised at how individuals are not really educated about the reciprocal impact of these conditions on each other, and kind of provision of corrective feedback. In terms of mechanisms, so as they are still under basically a study, but the main mechanisms that we believe could be effective in this type of interventions is first and foremost is developing this knowledge and also being able to observe this discrepancy about what they are doing in terms of that substance use behavior. And the goal of basically, it could be achieving some form of basically health or growth or like recovery post-surgery. So this discrepancy being highlighted in their mind. And the second one, which is basically driven from the social cognitive theories, is developing some form of self-efficacy to be able to basically start feeling ready for behavior change. So applications of these PFIs for pain and substance use are basically has been tested in various domains. I would still say it's in nascency, basically. But one of the areas that I think Joe himself has tested it is like trying to enhance smoking cessation motivation among populations who are living with HIV condition, who also use basically opioid medications and also smokers. So it's kind of a triple comorbidity. And the use of PFI has been tested there. The other area that I'm interested, I'm trying to basically implement as much as basically possible, and Grant basically funding allows, is trying to develop a motivational enhancement program within the orthopedic trauma and surgery settings that is a high need of smoking, tobacco, or any form of basically nicotine cessation, which could directly impact recovery. And last but not the least, one of the other colleagues are also trying to implement it within the population of people with chronic pain and hazardous drinking condition, and with a very cool, I think, tweak targeting pain-related anxiety as one mechanism within that PFIs. So as related actually to the last example that I mentioned, PFIs also have the flexibility of being integrated by within the other type of like a multimodal treatments. Like, for example, we can add minimal basically information about coping strategies for pain and related distress. And as you can imagine, it can also help with reducing emotional distress as a general, like anxiety and depression that is kind of correlated with pain and related distress. So web-based PFIs, or like what it used to be called like computerized personalized feedback interventions, now we call it online because everything is online and available, are having some advantages over the basically over the person delivered or like in-person type of PFIs. One of which being that it basically help overcome barriers like provider availability, which is a huge issue in the health overall, as we know, specifically for behavioral health interventions, and also overcoming stigma. It's obviously more cost effective and hopefully scalable as we get to the implementation phase. It provides the chance of immediate intervention, specifically for me, who I'm interested basically to implement it in post-surgery. And so having the basically fancy of providing this like a web-based link or something, one session, like 20 minutes, 30 minutes, very quick and brief, is something that basically add to the flexibility and hopefully improve the implementability. Anonymity, obviously, given the basically sensitivity of the subject, is another benefit. And last but not the least, it provides a standard, basically a standardized platform and featuring and content that basically has the promise of replicability across delivery settings. And in terms of the scalability, as I mentioned, so it's not only we hope it can address individual level problems, but given the high potential for disseminability, we basically predict a very reasonable and good public health basically impact. And we believe, and personally, I'm very hopeful that it is very suitable for integration in the clinical settings as my colleagues and I are trying to basically implement these. So currently the evidence for this efficacy or like effectiveness of PFIs in the realm of pain and substance use comorbidity, I would say like for some of the substances it's there are more evidence than the others, but what we really have here in terms of the published evidence, so we know one of the Joe's work, actually we were able to show that the application or implementing PFIs among people's with HIV diagnoses who are smokers and also using basically opiate medications directly help to increase knowledge of the interrelation between pain and substance use. And the other, I think it was a review paper that shows that for chronic pain and alcohol, basically misuse comorbidity, PFIs were able to show improvement in not only pain outcomes, but also decreasing problematic alcohol consumption. And I think it was again the other study by Joe that showed that like the PFIs are able to increase motivation to quit among smokers that are more like on the heavier side of smoking, more than 10 cigarettes per day. And in terms of broader impact, we believe that as we move forward with implementing these interventions in the real world and like clinical care settings, there are going to be reduction in healthcare costs and hopefully improvement in quality of life, and pain being one aspect of it, but overall functionality of the patients. In terms of basically research gaps, there's obviously so many research gaps given the nascency, but like the ones that comes to my mind for now and like maybe in need of immediate attention. One would be like how these interventions work for longer term outcomes for both pain and substance use in different populations, how they could be adapted for diverse needs of people with basically diverse set of experiences or contextual backgrounds. And again, what I believe could be some relevant future directions going to be basically the idea of combining PFIs with other interventions such as physical therapy. So this example is kind of dear to my heart because like I'm invested in PFIs in orthopedic trauma, and over there physical therapy is a common phenomenon for nearly every patient, with either being offered to receive it or they are receiving it. So combining these, like kind of creating a curriculum that every patient being offered to and receiving as a part of their recovery efforts is going to be something to be examined. And obviously, word of the day these days, leveraging AI, which I think honestly it has a very good, reasonable relevance with PFIs, given the element of personalization that PFI kind of leverages. And hopefully AI and the technology in this area can help us to make it, the personalization basically more optimized. And also basically hopefully investigating into what timing is optimal, what delivery format is optimal. Again, I go back to my own example of within the orthopedic trauma surgery, and it took a lot of back and forth with us and the surgeons and like the nurses and like all the basically stakeholders involved to get to basically to the decision of what timing is the best timing for inpatient delivery, which is a sensitive subject in orthopedic trauma, as you can guess. And so basically in conclusion, why PFI matters to me, they represent an effective, scalable, and accessible intervention for pain and substance use. So it sounds promising from the public health perspective. And I think things to be considered maybe is like one, how we can really integrate them into the standard of care for the people who are dealing with this comorbidity of pain and substance use. And also advocating hopefully for inclusion of PFI or its components within the actual like medical care settings, and basically increasing buying from the multidisciplinary care teams, hopefully. Thank you very much. And yeah, I don't know if am I done or not, but my presentation.
Thank you. Now we will have a moderated discussion, which will be led by Yenisel Cruz Almeida.
Thank you, Jesse. Thank you for both speakers for those great presentations. One thought that I think it would be great if the speakers could touch on was a comment earlier in the chat about this idea of, you know, when we're talking about the intersection of pain and substance use versus the intersection of pain and substance use disorder. And I think, you know, and again, in both presentations with different types of substances, for example, we've heard those terms. And so wondering how the speakers think about, both framing when we think about phenotyping as well as personalized feedback interventions. How do you think about those? And again, with the goal in mind of priorities in this particular working group, how do we strategize? Thinking about and addressing the needs of individuals that may be on controlled or non-controlled substances. Dr. Bakshai, talked about smoking, for example, but also, those that do not have an actual disorder, which is thought by many to be really important. So Dr. Simon or
Yeah,
Jafar.
Sure.
I can, oh, Jafar, go ahead.
Yeah.
Please go ahead.
Yeah, I mean, from clinical experience, I do work as a clinical pharmacist at the Pain Management Center as part of our interdisciplinary team. And I do think that patients who come with history of substance use disorders and chronic pain, are challenging population that really may require very careful attention. And I think teasing out some of those differences that you mentioned, Dr. Cruz Almeida, about, are people using controlled, medications, so substances prescribed specifically to take care of the underlying problem, right? That could be the pain. And therefore they're using it. Sometimes they may be taking more than we prescribe, which would put them into the category of the substance use disorder, right? Even sort of using more than that, versus patients who may have other conditions. They may be using, other illicit substances, which could be cocaine or other things, and how we think about managing pain effectively, efficiently, and safely in those patients. And I think the phenotyping becomes really challenging. And at what stage do you do this, right? Do you try to get a cross-sectional snapshot every time you're trying to think about a new intervention, whether it's pharmacological or non-pharmacological, and try to think about their risks of non-adherence, side effects? Or you try to think about of a more, genotyping versus some environmental exposure interaction, put them in some risk bucket that could carry over for a long time, with an individual patient, like a label that you put on them. And I think we need to be careful with that as well. So I don't think I have an answer, but I think it's important to try to tease those two components out and try to have as careful characterization at a specific time point as possible to inform the decisions.
Thank you, Dr. Hartunian. Dr. Bakshai.
Thank you very much. So if I hope I understand the question correctly, but from my basically angle that at least for this specific PFI presentation, from the PFI perspective, and also like if you want to think about implementing it in medical settings, I would see more relevance for basically trying to screen people with any form of risky substance use versus the disorder. So, and this target, just like for me, like from the angle of like implementing in medical setting, over there, you need to sell your product. And like with the medical people, you need to basically showcase that, oh, like I'm covering this amount of population, I bring this amount of money by covering. So it's more like from the SBIRT perspective, like a screening and brief intervention. So I would say, yeah. And also I see also HEAL has this huge emphasis on opioid, and sometimes I feel the non-opioid medications are kind of abandoned children or something like in that line.
Right.
Yeah, I would see like a relevance to both basic addressing both conditions or both side of the spectrum. But for PFIs, I would see more relevance definitely for risky substance use or like a non-disordered forms of substance.
Okay. Great, thank you. Dr. Bashai, let me follow up with you on, you were talking about tailoring to interventions and PFI to behavior change. Could you elaborate a little more on that? And then I wanted to ask Dr. Hartunian a little bit, do we see potentially as an important gap of kind of tying those together, so our, integrating our phenotyping approaches as you described to be able to lead to the personalized feedback interventions, Dr. Bakshai? Like, how do we kind of merge those in the pain field, and could that be something to think about for the future?
Yeah, I appreciate the question, and definitely, like I think PFI by default is like basically feeding from phenotyping, like the concept of personalized feedback. Like, what is personalized other than we know what that's the specific characteristic that person is? And I'm really happy because of the advances of AI, which like if we really like call PFI, like because PFI these days is really like what we call PFI is mainly computerized or web-based. So we have less of a list of like in-person PFIs given the limitations that is there. So I would say, yeah, definitely it can benefit from any form of phenotyping. And I would say we are currently benefiting from phenotyping that already exists by providing like the normative feedback that we are providing to the patients within the PFI context is directly coming from the phenotyping efforts like the work that Simon is doing. So yeah, I would definitely advocate for integration. And the way that I see it is already integrated. Like as we advance, we need to integrate more.
Thank you.
Maybe I can highlight a particular challenge maybe we currently have in the research landscape. I think clinically, a lot of the studies that we do with phenotyping are more association studies rather than mechanistic studies. So for example, when let's say we screen patients prior to surgery, and one of the things that pops up is pre-surgical opioid use as a risk factor for developing chronic pain after surgery, right? So, you look at the association, there's some statistical significance, but is it really the opioid use that does something, for example, to the brain that puts the patients at risk for developing chronic pain after surgery, or perhaps those patients are in pain prior to the surgery, that is what increases their risk, and the opioid use itself is just a measure that happens to be associated with the outcome, and we're falsely putting this into the causative component sort of or a box. And I think if we have more aligned preclinical models sort of to each phenotype, I think there is a potential to do more in-depth mechanistic work and try to understand how things are, or establish causation rather than act on association, because the fact that something is associated with the outcome doesn't necessarily give you sort of the mechanism to focus on to try to improve the underlying risk, and so that you can affect the outcome of interest. So I think this is where there's still a gap that I think we need to invest more in, really going from association to causation or mechanism-based studies.
And just to follow up on that, what are the, is there a need to kind of work on preclinical models that better basically forward and model the human experience? And again, even potentially using, persons with lived experience into the actual animal model, development and outcome measures?
Yeah, I think both. I think so. For example, what we suggested in this impetus, the HEAL RM1 project, is to think about aligning some of the outcomes. So for example, if you have substance use disorder, potentially, or you're thinking that it increases the risk of post-surgical pain, if you have a mouse model that comes to the surgery procedure with a pre-existing substance use, or you have, administered whatever substance of interest, does that mouse develop a different behavioral phenotype compared to a mouse that, didn't have that substance exposure? And does that align with a patient phenotype who came to surgery with substance use? I think there's an opportunity to think about sort of more nuanced animal models that align, not just because, like post-surgical animal pain models don't translate broadly to the patient population, right? We know that there's huge gaps. But our thinking is that, can we more carefully align the phenotypes and enrich the mouse models or the rat models to represent kind of the patient behaviors, or, anhedonia, or whatever you want to account for it, and then perhaps see if that can improve back translation. So I think that's one component that could be helpful. And obviously, patient perspectives are critical, I think, both for developing preclinical models that are relevant to patients, and definitely in clinical research to make sure that we're considering all the views.
Great.
I mean, it would be, yeah. I wonder how Katrina and Michael think about this, but yeah.
Just to add to what the last part that Simon mentioned, like I would say, like the concept of human-centered designs could come handy in the clinical models, basically including patients from the first step, basically of the ideation, design, and development of interventions we are developing, and hopefully we start seeing things from their lens versus basically like a post-fact testing of intervention.
Michael, were you gonna?
Yeah, so no, in response to Simone's question, I was going to say, thankfully, I don't think about it as much as you do, because you're making my head hurt. But one thing I wanted to comment on, and hopefully both can reflect, because I feel like I've heard it in different ways in both of your conversations here. And I know Jafar referenced it in his presentation, was this this added complexity of the temporal aspect, or what happens over time, especially post-incident. And I know this was true for myself, and I know, Simone, you were talking about, when is the appropriate time, or what makes sense when to take that sort of snapshot. For myself, it would be post-surgical. I was quickly reflecting back of what my journey was like and how quickly things were changing for me, not only reasons for substance use, how I was using the opioids, and then reasonings beyond that. I mean, immediately post-surgery, it was pain. Yes, it hurts using these things for pain. It is what it is. And then it quickly evolved to, these substances are allowing me to function. I saw this increase in quality of life, and then this quality of life sort of established. And then there was I need to maintain that quality of life, but it still hurts. I can honestly say I don't know that I was taking it so much to reduce the pain, but to allow me to continue the life that I now had, and see what that journey was going to look like. As dependence begins to occur, all of a sudden it's like, I need more to allow me to sustain that quality of life that I now have back, or at least beginning to emerge. And then it just steamrolls from there. And then the addiction piece for myself became this whole psychological mental health reprieve that I was experiencing with anxiety, depression, and all these other things that were happening. So when I think of this concept, or these concepts temporally, the complexity is mind-blowing on what can occur from a lived experience perspective. How do you even consider those complexities? Because again, temporally, it adds massive layers to this.
Mm-hmm.
I highly appreciate, I really appreciate you sharing that, Michael. And that's, I think, like the kind of corresponded with my last point on the use of human-centered design and inclusion of stakeholders in every step, including long-term outcome, explorations. Yeah.
So I'm going to ask one last question, actually, because both of you actually talked a little bit about the importance, really, of considering disparities. And it came up at different points. And now, Jafar, with the use of AI kind of based personalized feedback interventions, as you talked about, but even again with phenotyping, Simon, do any of you have any concerns about this potential risks of increasing disparities that already exist, or exacerbating some that we know are already here?
I take the first. With my limited knowledge of AI, I can see both sides of it. And I'm actually listening much these days to these like top people in AI, because we need to really be on the know what's going on. Like, it's going to affect all aspects of our life. And I think this is a relevant concern. So from my perspective, the way that I see AI, and I see the times is up so very quickly. So it can grow as big as, like, it's like the water in our house. Like, we just turn the faucet and water comes, and everybody has access to AI. Ideally, that's the scenario. But there also could be drawbacks, as you mentioned, like that, specifically because the AI is developing on the things that we feed it. So if people who don't have access feed it, it's gonna grow to be the bias towards those people. So sorry.
Yeah, and we know that not everybody has access to it. So I think we actually have to wrap up to stay on
Yep.
on time.
Indeed. I know we could talk about that for a long time. Thank you all very much. Next, for our next scientific presentation, we will hear about health equity and social determinants of health, presented by Antoinette Spector.
Hi, everyone. It's actually quite relevant, so we're just going to keep talking about the things that you all ended with in the last talk. So I am Antoinette Spector. I am an assistant professor, physical therapy and human movement sciences, and I also direct the dual degree Doctor of Physical Therapy and Masters of Public Health program at Northwestern. So I'm clinically trained as a physical therapist. So I was excited to hear the plug for physical therapy in this space earlier, as well as my scientific training in public health with a focus on addressing social determinants of health and use of community engaged approaches. So I am going to have my disclosure slide here saying that I do not have any disclosures to report. And I will move into briefly talking about all of the things that have been mentioned in terms of trying to understand the state of the science, gaps and potential impact, but really framing that from a health equity lens, which has already been touched on today with the nod towards pervasive health disparities that exist in both pain and substance use. So I'll start just by briefly touching on the state of the science, and I'm focusing again largely on it from a health equity perspective, and at that intersection of both substance use and pain. And so this slide is just to further highlight what we already know and to give the disclaimer that these statistics are flawed in that they can be different depending on the samples that we look at, as what was mentioned before. But I do want to at least note that in addition to us understanding that the burden of co-occurring pain and substance use is quite high, that temporality really is something that we should be thinking about as we focus on this health equity lens. And depending on, again, the sample that we look at, if we're focusing on people who have co-occurring pain and substance use, understanding that the vast majority report that their substance use disorder preceded their pain in some cases, versus it may be less common for pain to precede substance use disorders. Again, just as a way to kind of set the stage as to how we might be thinking about some of this from a health equity lens in terms of that reciprocal relationship. And the other piece of the science that I really want to touch on to ground us in health equity is the effectiveness of integrated programs. And to the extent that we have data available, it appears that incorporating behavioral pain management strategies into substance use disorder programs can actually promote better pain-related outcomes. So that is positive and something that has been shown in multiple studies. However, we do note that there may be outcomes that differ by sex, and the evidence can be mixed regarding the extent to which these types of integrated programs have positive effects on substance use disorder outcomes, depending again on the type of disorder that we're talking about and the type of actual substance outcome that we look at in terms of how are we actually defining success in abstinence versus reduction, et cetera. So again, just to note that we do understand that the burden is high, there is a temporal sequence that may be relevant, and that there actually are some treatments that have been shown to be effective within a population that does have these co-occurring disorders. But when we think about health equity as defined by the CDC, we think about it as the state in which everyone has a fair and just opportunity to attain their highest level of health. And this is where we start to see things break down a little bit in terms of our understanding of, again, the nature of co-occurring pain and substance use in the populations who might be more or less affected. And that's really where these gaps start to reveal themselves. So when we think about health equity, before we can move towards actually addressing it, we actually have to be able to detect health equities in where they exist and understand the determinants which might be actually contributing to the inequities that we're observing. And so one of the things that we lack, especially in the space of co-occurring pain and substance use, is surveillance and data. And so we do have some indication, particularly from a sex and gender perspective, that we might see, similar to the general population, a higher prevalence of chronic pain in females among the general population of people with substance use disorders, and that the presence of chronic pain may actually increase vulnerability for outcomes such as overdose in females, but then that it may lessen it for males. So there's some data to provide us some evidence to this. But when we start to look more broadly at other personal characteristics, we start to see that there's just really a lack of data that really helps us understand these things from an intersectional perspective, at the intersection of pain and substance use. So racial and ethnic differences, sometimes age differences, geographical differences when we think about rural populations or tribal communities, as well as to populations who may be socioeconomically disadvantaged. And when we think about phenotyping and personalized medicine, it becomes really hard to actually do that when we don't have adequate surveillance and data to actually capture both these differences, but how these things are complex and often interact in people living with multiple identities that may be interacting among one another. And so then when we move towards mechanisms, again, we come back to this ability to detect. And so thinking about temporality, the extent to which substance use began prior to the presence of pain and the extent to which the pain occurred prior. Well, these may be things that are quite nuanced and actually have quite a bit of difference depending on the subpopulation of interest. And we've talked about this already with respect to populations who may experience more or less pain, such as women, versus populations who may experience more or less pain as time goes on across the life course and how these things might intersect. Neurobiological differences as well. We understand that there are sex differences both in how pain is experienced, but also how substance use can be experienced for women in terms of escalation. And so again, being able to detect these differences among groups becomes really pertinent if we're looking at this from a health equity perspective, similarly with respect to psychological comorbidities and psychological coping mechanisms. As we move to understanding all of this in terms of understanding those differences can be moderated by various social determinants of health. In the area of pain, we understand that chronic stress or exposure to chronic stressors can exacerbate pain and also exacerbate substance use outcomes in isolation, but we really have no understanding of how those things might be compounded in a population who is experiencing both pain and substance use or risk factors for those. This is true for intersectional stigma, things such as structural racism. And so we begin to ask questions such as, how might factors such as age and sex influence these mechanistic relationships and vulnerabilities for co-occurring pain and substance use? And then which determinants might moderate those things and be most relevant to us understanding those disparities and outcomes by various personal attributes? And then finally, which are the populations that are experiencing these health disparities and are disproportionately exposed to the relative determinants? So from a mechanistic perspective, it's quite complex, but we have a lot to understand in terms of just who is being affected and how before we can even move towards being able to address a lot of these issues. Similarly, with respect to pain, in pain, we often think about, for people who may be receiving treatment for substance use, what is the relevance for transitions from acute to chronic pain? And others talked about minimizing pain interference to promote quality of life. With respect to substance use, if I am someone who is seeking treatment for pain, to what extent am I being screened to prevent my initiation of harmful substance use behaviors? If I have a history of substance use, how am I being screened to support my prevention of relapse? And as from a harm reduction perspective, how might I be screened to prevent my risk to experience an overdose event? And so again, risk stratification becomes quite pertinent here with respect to both of these settings, which populations might be at higher risk to experience that acute to chronic pain transition and to experience pain that becomes higher levels of pain interference and more risk for high impact chronic pain. And conversely, which populations may be particularly at risk for that initiation of those harmful substance use behaviors, relapse, and overdose events. And finally, which again are the determinants that are most relevant for us to understand these populations who may be at higher or lesser risk. And finally, with respect to treatment, for people who might be actually seeking treatment for pain, we are really focused on the extent to which we have universal or personalized ways in which we can adequately assess substance use behaviors across the continuum. It's come up that it's not only just about substance use disorder, but also the extent to which we can understand people who may be doing substance use behaviors that have not yet fallen into the continuum of being diagnosed as disordered use. Additionally, we talked about related mental health and social comorbidities that could be identified and tracked so that we, again, have opportunities to understand those moderating influences. And related to that long-term trajectory, being able to provide that ongoing support, and vice versa with respect to those receiving substance use treatment. How can we provide that pain assessment and treatment, address those comorbidities, and provide that ongoing support? And so as we think about these personalized programs and these integrated treatment programs, to what extent is there equitable access to those programs, which has come up already? To what extent are those programs able to be assessed for groups who we know already have disparate access to traditional pain programs and already have disparate access to our traditional substance use programs? How might those access disparities be compounded for people who are trying to find access to these more specialized integrated programs? And similarly, as we start to evaluate programs that have been shown to be potentially efficacious, to what extent are they equitable across various subgroups? And so being able to actually track the extent to which these programs that are being piloted and potentially scaled up, to what extent are they achieving equitable outcomes? And then finally, which of those determinants might need to be addressed to ensure that we both have equitable access to programs and that we're achieving equitable outcomes in programs that are being piloted and scaled up. So with respect to impact, we come back to this idea of detecting and understanding to even move to a place where we can begin to actually reduce and eliminate health disparities. And so again, back to the idea of surveillance. I cannot stress this enough. Part of this is, yes, being able to recruit and bring in diverse populations into studies, but we have to be able to actually identify populations who have increased vulnerability so that we do not end up having unintended consequences from the implementation of programs that we deem to be effective. And we have to understand why patients may be experiencing disparate outcomes when we do implement strategies. When we do implement strategies that are meant to improve their outcomes. And then finally, being able to intervene across multiple levels. And again, collecting adequate data to do so, and also recruiting and retaining diverse populations so that we can actually see those effects. And then finally, being able to evaluate the impact of those interventions on the health disparities that we are, in a lot of cases, assuming may be the case, but also those that we have identified by creating the infrastructure to identify things that have been provided evidence for, and some of the surveillance work that needs to be done. And so I'll close with what I see as the key takeaways here within the health equity space, because we know that the burden of co-occurring pain and substance use is quite high. And we do have some early evidence to support that these integrated programs, along with other things that have been mentioned, some of the personalized programs, may be an effective approach towards trying to reduce the burden of this condition, but we have quite a limited understanding of the health inequities. Who are the people who are most affected? What are the reasons that they're affected? In what ways are they perhaps experiencing higher risk for both either pain or substance use, or poor outcomes in each of those domains? And how? Is it because of socioeconomic status? Is it because of geographic limitations and access? We have limited understanding of how these are being affected, which really hamstrings us in our ability to actually intervene upon these things, because at the end of the day, we are unable to address what is unknown. And so we need the infrastructure in place to actually seed the ground, to begin to acknowledge where disparities exist and actually address them over the course of the next 5 years or so. All right, that is it.
Thank you very much. Our next presentation will be on older adults, given by Lisa Leroux.
All right, thank you. So my name is Lisa Leroux. I'm a clinical psychologist and researcher at Mass General Hospital and Harvard Medical School. And my research focuses on the intersection between chronic pain and substance use in older adults. And I'm really grateful to have this opportunity today to talk about some of the major research gaps that exist in this area. I am supported by the NIA, and I've received funding from the USD Prescribing Network. I just want to start by providing an outline of this talk. First, I'm going to talk briefly about our aging population and why older adults warrant special consideration. And then I'm going to talk about both prescription opioid use as well as non-opioid substance use. Within each of these areas, I'll discuss what we already know and identify some key research gaps. And then I'll end by summarizing the importance of addressing these gaps. So let's start by talking about the aging population. By 2030, 1 in every 5 individuals in the United States will be 65 or older. And by 2034, just 10 years from now, older adults will outnumber children for the first time in US history. So to effectively support our aging population, we need to understand the characteristics that make older adults a distinct and somewhat vulnerable group, especially in the context of pain and substance use. So first of all, we know that many older adults are living with chronic pain. We recently conducted a nationally representative study of older adults and found that 38% had chronic pain. Chronic pain in older adults is associated with many different adverse health outcomes, but despite its impact, it remains underassessed, underdiagnosed, and undertreated in this population. Older adults also have really high rates of multimorbidity. We know that 80% of older adults have at least 2 chronic conditions. In addition, 39% of older adults are prescribed at least 5 medications. So both multimorbidity and polypharmacy are really important for us to be considering when thinking about pain and substance use in this population. Age-related changes in pharmacokinetics and pharmacodynamics also make older adults more sensitive to pain medications, as well as to the effects of non-opioid substances like nicotine, alcohol, and cannabis. And this puts older adults at greater risk for experiencing adverse substance-related effects. Many older adults also have limited access to treatments. Many non-opioid pain medications are inappropriate for use in older adults. And although non-pharmacologic treatments offer a lot of promise for both chronic pain management as well as for treating substance use disorder, older adults use these treatments at lower rates and may face greater barriers to care. For example, communication challenges can prevent older adults from accessing these treatments, particularly for patients who are nonverbal or have hearing loss, and physical and cognitive limitations can also be barriers to care. And finally, we know that ageism remains incredibly pervasive in our society. Older adults often believe that pain is a natural consequence of aging, and this prevents many from seeking treatment for their pain. Age-related stigma can also prevent older adults from seeking substance use treatment. For example, many people hold beliefs that addiction is a younger person's problem, which makes some older adults more reluctant to ask for help. So understanding these unique needs of older adults really, I think, provides a foundation for addressing specific challenges they face, like opioid use. Opioids are one of the most common pain treatments used by older adults. Nearly a quarter of Medicare Part D beneficiaries received a prescription for opioids in 2021. And our research team recently found that 22% of older adults in the United States report using prescription opioids for chronic pain management specifically. These high rates are concerning for a few reasons. First, there's quite limited evidence that opioids are actually effective for treating chronic pain in older adults in the longer term. Also, age-related changes and high rates of polypharmacy can increase risk for adverse opioid effects, including overdose, falls, fractures, and cognitive impairment. And at the same time, the prevalence of opioid use disorder has increased more than 3-fold in older adults in the last decade. So as a result, national guidelines have recommended limiting opioid prescriptions in older adults. And that brings us to our first major research gap. We lack research on the effects of opioid regulations and opioid deprescribing in older adults with chronic pain. Initial qualitative work conducted by Dr. Christine Ritchie suggests that the opioid regulations have had unintended consequences that disproportionately affect older adults. For example, some providers might now avoid addressing pain in older adults altogether. For example, one older adult participant said, I'm a little concerned with this whole opioid crisis is making doctors afraid to do anything for their patients. It's also been noted that older adults suffer disproportionately because they face additional barriers to alternative pain treatments. Another patient said if they were to go off their opioids, they'd be in unbearable pain. They asked their doctor every month, is there anything else that I could be on to help get off the opioid? And they say, not really. Other older adults have pointed out that opioid regulations have posed additional barriers for them to access care. For example, one person said, if I'm in a lot of pain, I can't send somebody to the drugstore to refill my oxycodone. I have to go there. It doesn't matter if I can't walk. So we really need additional research on the potential iatrogenic consequences of opioid regulations in older adults. And this work will help to reduce any unintended harms associated with our efforts to reduce opioid misuse, as well as inform strategies to ensure that opioid regulations don't also reduce access to effective pain management in older adults. Due in part to increased opioid regulations, there's also been a greater emphasis in recent years on deprescribing opioids in older adults. And deprescribing can be defined as the planned and supervised process of reducing a medication or stopping it completely if it's determined that the medication might be causing harm or might no longer be offering its intended benefits. And recently, investigators published clinical practice guidelines for deprescribing opioids. However, we still don't have any specific guidelines for deprescribing opioids in older adults with chronic pain. So to reduce the number of older adults prescribed opioids and consequently prevent opioid misuse and the development of opioid use disorder in this population, we really need to prioritize research that will inform guidelines on opioid deprescribing. Specifically, we need to know which older adults should be considered for deprescribing, when to deprescribe opioids, and how to deprescribe opioids in a way that minimizes harms. Speaking of harms, one of the potential consequences of opioid deprescribing is that older adults might turn to other substances to cope with their pain when opioids are no longer available. We know that pain can be a strong motivator of both opioid and non-opioid substance use. And our initial qualitative work has shown that older adults often identify pain as the strongest motivator of turning to non-opioid substance use when their opioids are deprescribed. For example, they've told us that with the pain level being what it is, I'm forced to use cannabis. One older adult said, if the pain's so bad, I say, well, I want to knock myself out and I'll drink a glass of wine. Someone else explained that you're in so much pain, you can't even walk across the room. At that point, you would try anything that you think might work. So we really need research to inform the development of opioid deprescribing interventions that maximize health benefits while minimizing risks that older adults will transition to non-prescribed opioids or non-opioid substances when they're no longer prescribed opioids. So let's talk about what we know about non-opioid substance use in older adults. Well, we know that it's common. Nearly 1 in 8 older adults smoke cigarettes, and even more than that engage in binge drinking. We also are seeing that about 10% of older adults use cannabis. And there's evidence that rates of both alcohol and cannabis use are increasing in older adults. In the general adult population, we know that chronic pain and non-opioid substance use frequently co-occur, but research focused on this co-occurrence in older adults specifically is quite limited. We do have some initial evidence suggesting that older adults with chronic pain are more likely to report a history of cigarette smoking than those without chronic pain, and that greater pain severity is associated with a greater likelihood of smoking. We also know that co-occurring pain and alcohol use is common in older adults. We recently conducted a scoping review to see what's known about this in the literature. And although the literature was very limited, there was evidence that most older adults with pain drink alcohol, and up to 28% engage in hazardous patterns of drinking. In terms of cannabis use, we recently found in our nationally representative sample of older adults that 1 in 10 older adults with chronic pain report using cannabis for pain management. And prior work has shown that severe or chronic pain is the primary reason why older adults seek medical cannabis. So we know that non-opioid substance use is really common in older adults with pain. But this brings us to our second major research gap. Research on the impact and treatment of non-opioid substance use in older adults with chronic pain is incredibly limited. And I think the main reason for this is that older adults have historically been underrepresented in most research on pain and non-opioid substance use. This is in part because people aged 65 and older have historically been excluded from research studies. And in addition to this, we frequently exclude patients based on comorbidities or taking certain medications. And this prevents many older adults from participating in research studies and then limits our ability to generalize study findings to other populations. Even when older adults are included in this work, most studies still don't report the proportion of participants who are aged 65 and older, which makes it nearly impossible for us to know whether the findings apply to our older patients. And so, as I've mentioned throughout this talk, older adults face numerous challenges that increase their susceptibility to the negative effects of both pain and substance use. So we really need research focused specifically on older adult populations to allow us to understand the relationship between pain and non-opioid substance use in this population. Since older adults have historically been excluded from work in this area, we also don't currently know how distinct patterns of substance use differentially affect pain-related outcomes in older adults. And we lack research showing how the presence of pain impacts substance-related outcomes. It's possible that older age amplifies bidirectional pain-substance relationships. So consistent with the reciprocal model of pain and addiction, we need longitudinal research focused on understanding bidirectional relationships between pain and substance use in older adults specifically. And perhaps even more importantly, we need to better understand the impact of co-occurring pain and substance use on older adults. For example, how do co-occurring pain and substance use disorder affect patient-important outcomes like physical function, the development of geriatric syndromes, and quality of life? We also need more research into specific mechanisms underlying relationships between pain and substance use in older adults. Prior work has suggested numerous different mechanisms underlying these relationships in the general population, but it's possible that there are mechanisms unique to older adults. For example, it's probably especially important that we understand the role of different medical factors like comorbidities and social factors like loneliness when studying co-occurring pain and substance use in older adults. We also lack treatments that address non-opioid substance use, specifically in older adults with pain. So we need more research to identify both mechanisms and to develop interventions to treat pain and substance use in older adults. These interventions will then help us to reduce the risk for adverse pain and substance-related outcomes and improve the well-being and quality of life for our aging population. So I want to just briefly summarize some important conclusions. Older adults are a unique population that warrants specific attention, and we need more research to understand the effects of opioid regulations and opioid deprescribing in older adults, including the development of clinical guidelines and tailored interventions for opioid deprescribing in this population. This research is really essential for preventing opioid misuse, preventing the transition to non-opioid substance use, and preventing other unintended harms, while at the same time making sure that older adults can continue to access effective pain management. We also need more research on the interplay between pain and non-opioid substance use in older adults who have historically been underrepresented in this work. These studies will provide really important insights into the impact of co-occurring pain and substance use in older adults and pave the way for tailored interventions that improve pain, substance, and aging-related outcomes. Thank you so much.
Thank you. Our next presentation will be on mental health comorbidity, presented by Kurt Krumke.
So the focus of my presentation will be on mental health comorbidity. I have no conflicts of interest to disclose. This will be a slide of interest to everybody. So there's a metric called years lived with disability, which takes into account how early in life it starts, how much disability it causes, and how common it is in the population. And there was an article that looked at the top 30 diseases globally. These are the top medical disorders, and the number in parentheses indicates where it is on the list of 30. collectively, these medical disorders account for 8 million years lived with disability. In contrast, these 5 pain conditions account for more years lived with disability, 9.7 million years. If you add to that our other topics today, depression, anxiety, drugs, and alcohol, if you add everything on the left, it's more than double the years lived with disability compared to many of the medical disorders we focus on. The 2 principal sources for my presentation is my trial experience in pain, depression, anxiety, and opiates. Most of these have been pragmatic, collaborative care, telecare, step care trials. I've had less experience actually in substance disorders outside opiates. In preparation, I did a really, really rapid literature search from 2010 on, looking at meta-analysis or reviews, and crossed it with pain and substance, pain and alcohol, pain and psychiatric, and pain and mental. Not pain and depression or anxiety or pain and opiates, because that literature is too big. I ended up with 15 selected reviews of half of which I will use for this talk, and I have those references at the end of the presentation. Really, I guess my presentation's looking at the triple threat, this conference workshops on pain and substance use disorder, but then there's this other big circle of mental health comorbidity. Ideally, we would focus at the sweet spot here of pain, substance use, and mental health comorbidity. But much of the literature is on these 2 boxes, pain and mental health comorbidity or pain and substance use disorder. I would say by far and away the 2 big ones for mental health comorbidities, depression and anxiety. And paradoxically, I will talk less about that data because the data is so convincing that depression and anxiety and the research on treating depression and anxiety is so convincing. I will only spend a small amount of time on that. The substances, the most common ones are these 6. What I'll talk about a little is the top 4 here. I'm just going to have 2 slides on a trial, a HEAL trial. We're a second site on. It's from the PIs are at Kaiser Washington, Kathy Bradley and Lynn DeBar. It's the MyCare trial. It uses an encouragement design. Eligibility are adults with an electronic health record diagnosis consistent with past year opiate use disorder, which would either be an ICD diagnosis or on buprenorphine for opiate use disorder, and a PH29 depression score greater than 10 in the past week. These are the clinical features of the population. You can look at those of these 800 that are in the trial. Of note, a third were on buprenorphine, which is much higher than you would see in primary care practice, but that's because that was one potential eligibility criteria. It's going to be much less than that in primary care. Notably, a third were on opiates. So even though they all had a diagnosis of opiate use disorder, a third were on opiates. What about the mental health diagnoses, which is one of the foci of my presentation? Well, as you can see, this confirms that depression and anxiety are the big 2, but then the next 3 are PTSD and 2 types of substance disorders. This was by chart review. When our nurses interviewed the 400 patients in the intervention group, we also discovered 2/3 had chronic pain, and these patients with opiate use disorder. 57% had sleep problems, and we find this is often the hidden morbidity that we tend not to focus on so much. And then a third had non-opiate substance use disorder in addition to their OUD. I'm notorious for rules of thumb, so take this with a little bit more than a grain of salt, but look at this as me just starting to simplify things. What's the 10% rule for chronic pain and substance use? Well, opiate use disorder occurs about 10% of chronic pain patients on long-term opiate therapy. Also, more than half of patients in substance use programs who are on non-medical prescription opiates have pain. What about alcohol? There's moderate to heavy drinking in 15 to 20% of patients with chronic pain, and chronic pain has a 2-fold increased risk of alcohol use disorder. Now, paradoxically, Epidemiologic studies show alcohol use may be associated with a lower risk of chronic pain. So there is a possible analgesic effect. But moderate use may improve pain, whereas the effects of heavy use are inconclusive, some showing making pain better and some showing heavy use making pain worse. Also, alcohol use disorder and opioid use disorder increase the risk and also decrease the treatment response of one another, as well as that of comorbid pain. Benzodiazepines, about 10% of chronic pain patients may develop a sedative use disorder. Cannabis, about 10% of chronic pain patients can develop cannabis use disorder. A few practical suggestions, because this comes up a lot in practice. What about managing comorbidity? I mean, if you have more than one disorder? Well, one is to screen. So if you have one of the conditions we've talked about, it should prompt screening for the others: pain, depression, anxiety, and substance use. When might you treat sequentially? If one condition is major and the other is minor, or if one condition is a greater treatment priority for the patient. When might you treat both? Well, if they're both causing substantial distress or impairment, or if you treat one and it remains bothersome after, if the untreated condition remains bothersome after treating the first condition. The other thing, measurement-based care is a big thing nowadays, especially for pain, depression, and anxiety, and we have responsive scales. I think for substance, we have good scales for screening and diagnosis, but it's less clear what criteria are for improvement. So as we try to move to measurement-based care for substance use disorders, I think there's more work to be done. I'm going to show just several slides to contextualize our current treatment of pain, because this is heavily important to our current treatment of substance use disorders. And the first is on medicines. So the review of the literature looking at rating pain on a 0 to 100, 5 to 10 points on a 100 scale is usually considered clinically important, a minimally important difference. Now, if you look at where the most medication trials have been for low back pain and osteoarthritis, two of our most common pain conditions, you will see that most of the positive evidences for these two drugs, medicines, NSAIDs and opiates, and a lot of trials for both. And I only mention that because obviously NSAIDs are the go-to, but there's a lot of contraindications to NSAIDs in people who have renal disease, gastrointestinal disease, diabetes, heart disease on direct anticoagulants, and so forth. So it's not the medicine for everybody. I want to have two slides looking at the three worst outcomes we fear with opiate prescriptions. One is becoming a chronic use, one is developing a disorder, and the third is fatality. Two of them I'm going to show on this slide. And these are studies that have looked at how often after people get an initial opiate prescription, do they develop chronic use and do they develop an opiate use disorder? And the bottom line, about 1 in 20 develop chronic use and about 1 in 200 develop an opiate use disorder. What about the third and the most worrisome consequence, an opiate overdose that's fatal? And this is data comparing patients on long-term opiate therapy. And the reference group are those on low dose morphine, less than 20 milligrams equivalent per day. So the number needed to harm for a fatal overdose is 667 who are on more than 50 milligrams and 400 on more than 100 milligrams. Now, just two slides on non-pharmacologic therapy. This is for low back pain, where has been the largest research area in chronic pain. You can see there's been a lot of trials and a number of non-pharmacologic therapy, of which I would say I'm a big believer in it, and it should be right near the top of treatments we offer. Notably, a number of them require active work on the part of the patient. So these are noted by A. And we have a whole session on non-pharmacologic treatments for chronic pain. So I'm only indicate 7 caveats, even though I think it should be the go-to treatment we use. Evidence standards are not as strict as FDA is for medication. Placebos are not quite as perfect as placebos in drug trials. Usually, many of the treatments require multiple sessions and, more importantly, patient motivation and work. They've not been proven in most cases to be superior to medications, but they can be as effective. Evidence for long-term efficacy has been a problem with all medications and all non-pharmacologic treatments, and most pain is chronic for years. There's a shortage of trained and interested providers, and really importantly, there's variable reimbursement in our healthcare system. Cannabis for chronic pain, we have a session this afternoon on it, just a few points to make. There have been systematic reviews, including one by ARC, which is, these references are below. What's clear is it's effective in neuropathic pain, but mixed evidence for other types of pain. Harms are being evaluated, and there are harms. Importantly, most trials were short duration, 2 to 15 weeks, and used synthetic FDA-approved cannabinoids rather than more complex marijuana products. The reason I mention that is I look at this a little bit like St. John's wort for depression. That's another interest of mine. There is evidence St. John's wort is effective for depression, but when people got St. John wort's preparation, one never really knew the dose within it. So that could be an issue to think about. And other data suggests that the pain effects of cannabis probably are similar to other analgesics. It is effective, but it's not the super analgesic. Last slide before my research gaps recommendations is what I call the perplexity of pain referrals. I'm a primary care physician at the center. And where do I go to if I want to refer a patient? There's many providers involved here, and there's some not on the list, but there's only a minority of those in each specialty is interested in the hot potato of chronic pain. So when I have a person with cardiac disease, I know I refer them to cardiology. When I have a patient with pain, who do I refer to? It's less clear. So research gaps, this is my last slide. The ones that I thought about is, with the initial CDC recommendations, we said there's no role for opiates in chronic pain anymore. One of the collateral damage was the use of opiate therapy in acute severe short-term pain kind of went away. And we've talked about post-op and trauma-related. I think the problem in the past is we didn't give people a prescription for 5 days and then monitored their pain in the next couple of weeks. We gave them enough for 90 days and we didn't monitor. So I think if there is a role, I think there is a role in some people with these kinds of pain, including cancer pain, but we have to be very careful. And is there any residual for opiates as a last resort? Cannabis, we have a session this afternoon, but it'll be interesting to think. It's because it's increasing the use. What is the niche of increased cannabis use for the treatment of chronic pain? Measurement-based care. I think we need to have work on validating scales to monitor SUD treatment like we have for pain, anxiety, and depression. There are some promise measures out there, but their use yet has not had wide uptake. The site of care, based on my last slide, which patients should be principally treated in primary care, which I can tell you as a primary care physician is going to be a vast majority, but which should be principally treated in specialty care and which should be co-managed. Finally, we just don't have evidence on long-term treatment. I mean, one of the criticisms of opiates is we don't have evidence for beyond 12 months. That's the case for most pain treatments. And in closing, what kind of research designs? In addition to clinical trials, I think cohort studies of different types of pain, maybe a Framingham study of chronic pain, electronic health race, EHR-based studies, either using pragmatic trials or observational studies, and maybe smart trial designs. And here's the references. Thank you.
Thank you very much. Next up, we will have a discussion of these last 3 presentations moderated by Ebony Winford.
Hello, everybody. Ebony Winford. I am also a licensed psychologist, and I'm the Vice President of Research and Health Equity at Cherokee Health Systems, a federally qualified health center in Tennessee. And so I want to start by thanking our three presenters, Doctors Spector, LaRoe, and Cronky, for this breadth of the discussion. And I want to start with the last question that's in our Q&A box, because it was actually one of the ones I wrote down that I was going to ask you. So I just want to go ahead and get a twofer if I can. It's going to be long, but hold on with me, okay? So a common problem in applying equity-based analyses is that we have small samples, especially when we're considering several intersecting identities. Most of the research gives descriptive tables. We get a sense of the sample demographics, but we also don't see those subgroup analyses by those demographics and intersecting identities. So that makes it really hard to do meta-analyses, which give us additional information. There's some debate about whether or not we have actually sufficient power to present the subgroup analyses, but what do you all recommend? Do you present the subgroup analyses and outcomes recognizing that you have low power? Is there some sort of database that people can pull from? And I'm gonna throw in another piece. What are some of the unintended consequences of those subgroup analyses, even in the absence of low power? And whoever wants to go first, you can hot potato it if you want to.
I'll go as a non-expert in the field. So
Come
I'm
on.
not an equities. I am not an equities researcher, but my thought is that a lot of the things we've used available to us, like race, ethnicity, other factors, gender, age, don't have the social determinants of health. So we've sometimes drawn false conclusions with variables we don't have. So it's not only a sample size issue, and we still, in much of the prior research and much EHR data, we're still way far behind on social determinants of health. So I would just put a cautionary note there. As we study equity, we need to build that in.
Yeah, I definitely agree. And I think the other thing I want to add is I think this really underscores the need for large national data sets that are adequately powered. So I think we need national studies looking at pain and substance use longitudinally in a nationally representative sample of adults throughout the United States.
Well, and in future research, I think maybe the NIH needs to, mandate that there be social determinants of health measured as parts of study. And there are good scales for it. We could figure it out, but I think we're not going to get it unless we start to insist on it.
Yeah, and just to piggyback on that, I think we would all agree that aspirationally we just need better data, which I think is kind of what I was alluding to. But in the absence of that and, people, suffering in real time, how can we optimize what we have? And I do think there's a world in which we can take what we have and provide context. And I think that often is what might be missing, is that we draw conclusions without providing adequate context so that people can accept those caveats in terms of the interpretation. So I think more clarity around interpretation is best available when we're understanding we are dealing with imperfect data.
And I appreciate that caveat, Dr. Spector, because one of the questions I wrote down from your presentation is, how do we contextualize the results such that we don't reinforce the stigma and the structural racism that has contributed to the disparities that we see in pain management when we're looking at race, ethnicity, gender, all those things, and how much context is enough, and what context do we even need?
Yeah, that's why health equity is hard.
Look, same.
However, I do think that little things such as the framing, I think at times, and particularly researchers who may not be well versed in health equity, there can be value in having multidisciplinary research teams who incorporate people who do have health equity expertise onto those teams, so that we are not pathologizing communities by talking specifically about race, but really providing the context as to, it is not the race that is the determinant, but the potential racism, sexism, ageism that is likely the contributing factor to why groups experience. So I think even small things like that in terms of how things are framed can help with the interpretation, so that we, again, are not pathologizing differences, but adding the context as to why certain groups are experiencing disparate outcomes as a starting point, again, best available at times with limited data. And I also think we have to, and I thought Dr. Leroux did a good job of this, of amplifying qualitative research at times and community engaged research. In the absence, again, of national population-based data, there are some smaller qualitative studies that can shed light on lived experience and offer that context that can add the richness to trying to understand these more personalized stories.
Yeah. We got a lot going on in this chat box, and I don't know if I'm gonna get to all of it, so I may just randomly pick one. Ooh, okay. Here we go. Do we have a need for research on broader or more global questions of how and when patients from trusting relationships and care where they feel understood? I'm misreading. Wait. So how do we find out those things from those trusting relationships so it's not entirely focused on pain and substance use? So how do we use the relationship, I would ask, to identify those underlying challenges that contribute to the disparities and discrepancies that we see? Is it that we need to understand better, express better empathy? What do we do to get at that?
I think talking about what's important to the patient, right? And so I think this speaks to the need to include patients in research and from a clinical lens too, just asking patients what's important to them. And so if it's quality of life, well, what's getting in the way of that? And I think that will bring up some of these issues that we are all interested in thinking and learning about.
Yeah. When I'm working with patients, I ask them if I have to use a rating scale for pain, I'll say, what's your current rating? What's an acceptable rating of pain for you? And then how do we get at using your values, the things that are important to you, to help you live in line with those things, also recognizing that pain is there. I wish I could make it become zero, but we can't. How do we get you to a level that's acceptable for you? And I think that piece you're talking about, just simply asking, may be what's missing sometimes when we want to know like the root cause of the change.
And just finding out whether pain reduction is their primary goal too, right? Like I think sometimes we as clinicians and researchers can assume people's values and priorities, but I think it's so important that we ask them and make sure we're prioritizing the outcomes that are important to them.
I love that.
To piggyback on that, I think it's also important to think about the settings in which these types of relationships are more apt to be developed. So I'm biased, I'm a physical therapist. So I know in the pain management space that we spend quite a bit of time with people and often longitudinally over the course of several weeks. So I think evaluating too, who are the appropriate or most appropriate providers in some cases who can be trained to help to have these conversations and help facilitate some of that goal setting, and where quality of life is already tends to be a key goal. But I would say in the workforce that we are not always well trained to do that depending on the specialty. So I also think where that occurs often matters as well. And are there better or worse ways for that information to be developed and for those goal setting priorities to be established?
That's one of the questions that has come up several times, is where should this care occur? Who should be on the team? Dr. Kroenke, were you going to say something before?
No, I was just going to say prioritization's a big issue because most people with pain have depression, anxiety, and more than one substance. I mean, so these things, and so I think, plus in a medical setting, they have medical problems. But the two questions I find most useful is which is most important to you, which has already been suggested, and second, do you want treatment for it? Because a lot of people, that's a big identifier. Is it something they want treatment for? So I'd say those two questions are probably, useful as an entry point because you can't treat it all at once.
Dr. Leroux and Dr. Kroenke, you raised a great question about, again, just centering the individual who's living with the pain. One of my all-time favorite patients ever, we were trying to work on improving his diabetes, and we were talking about A1C, and he said, yeah, my AC1 is great. And we were like, no, baby, it's not AC1. So instead of focusing on his AC1, we had to figure out what are you missing out on when your A1C is too high? And he like going outside throwing footballs with his grandkids. So we focus on how many days can you play football with your grandkids? And I wonder how we can reframe the conversation regarding pain management. You know, how can we increase the days you can do the things that are important for you? And how do we change our treatment to be in line with that? Can we do that? Can we imagine a treatment where it is value and function oriented rather than simply pain reduction on a number oriented? And I've heard everyone say we need to improve research. I got a big question for y'all. How? How do we get people in these trials that are representative of the things that are missing? What's missing? Why don't we have them? How do we fix that?
There's a paradox sometimes that science likes to focus on one problem to the exclusion of others. But what we're talking about today, that's really what you get out of that tends to be not as generalizable. So I think one way is, I'm not saying science projects shouldn't focus on one primary thing, but another thing we can do is measure the others. So like if you're doing, a study in back pain, I mean, at a minimum, you measure depression, anxiety, and substance use. You'll find a lot of them because a trial eventually becomes a cohort study as well. And so sometimes just simple measurement of things. And another would be broader trials. And there are some collaborative trials, which is focused on people who have pain and a mental comorbidity and one or more substances. And some of those have shown a positive effect from transdiagnostic treatments. So I would say increase the breadth of what we include in our studies. And if you're focusing narrow, measure broad.
What about the people who are missing? How do we get them in there so we can ask those questions Dr. Kroenke is mentioning?
Yeah, I was thinking that a lot of the structural challenges that preclude people from accessing health services can also be quite relevant in terms of people being able to participate in research. And so addressing those kind of social and structural factors before we even get to the actual research question is oftentimes needs to be happening before we even get people involved in community engaged approaches, stigma, trust, all of those things in terms of building trustworthiness as a scientific institution becomes really important to even provide the possibility that people will be participating in research. So investment, I believe in that community engagement on the front end, and then, like creating some sort of, as has been done in the past, like some, a little bit of incentive or positive or negative for people, including certain variables and community engaged approaches within their studies, at least outlaying those strategies. And I think Dr. LaRoe brought up a good point about criteria for participating in trials, and that just being another structural disadvantage that continues to perpetuate inequities over time.
Yeah, I agree with everything that's said. And I think from an older adult's perspective, just making sure that there are no age limits on eligibility for participation. And then again, relaxing restrictions against comorbidities and concurrent medications, those kinds of things. And I think that might take some training of IRBs and funding agencies, right, to show why some of these things aren't necessarily high risk and they're unnecessarily excluding people who are important to include in these studies.
And I want to highlight a word you said, Dr. Spector, that I want to make sure no one else misses. You said trustworthiness, not building trust. And I'm just going to push pause because this may be the last question I get to ask you all. How do we, as people who operate within the scientific, medical, psychological insert space here, how do we work to build trustworthiness in the systems and the programs that need people who have not been respected in research previously to actually participate and trust us? Because when we say, how do we build trust, that means it's on them to do better, but really it's on us. How do we become trustworthy to people so we can get them into these studies that help us answer these questions? And so 10 seconds for each of you all to solve all the world's problems.
I will just quickly say, and I wanted to highlight something I saw in the chat about reimbursement and terms of trustworthiness. And I just think one aspect of that is people are interested more in compensation, but community engagement also means that people get to be involved in both the design, the implementation, and the dissemination of study findings. And so I think outside of compensation, there's actually meaning that people derive from being able to participate in studies. And I think if we, focus more holistically on the benefits of participation beyond compensation, I think we may see that people are more likely to engage and be retained in some of our studies.
And I know we're out of time, but I already asked for all 3 responses, so we're going to get all 3.
I think community engagement from the very beginning of the research process is really important and key. And also transparency about the research process, sharing results back with the communities who are impacted by them in a way that's approachable and understandable and accessible to all.
And I'll close with, I agree with that. It's not all about trials. I think trials is what we value at the highest, but I think we can get a lot of valuable information from cohort studies, electronic health records, where people, are not enrolling on a trial. If we gather the information correctly, includes social determinants of health, as well as disease registries, which for chronic pain. So I'm just thinking there's things besides trials which are a little bit easier to get into trust-wise than a trial, which you feel like you're being experimented on.
Thank you. And I will defer back to our host.
Thank you very much. Now we are going to have a 10-minute break. We will see you back at 25 after the hour. Okay, we have less than a minute left in the break.
Jesse, can I go ahead and share my screen?
Yes, please. Lamont, can you unshare yours? Thank you. Okay. Lamont, are we good to begin?
Yep, all set.
Great. Welcome back from the break, everyone. Our next scientific presentation will be about buprenorphine and will be presented by William Becker and Amy Bonner.
Hey, good afternoon, folks. Good to be here. My name is Will Becker from Yale School of Medicine and VA Connecticut, and I'll be presenting on buprenorphine with Amy Bonner, who will follow up. We have no conflicts of interest to disclose. First, want to provide some background about buprenorphine. So it is a synthetic opioid. It is a partial agonist at the mu opioid receptor. And as such, it is a potent analgesic, but as demonstrated on the figure on the right, it has a ceiling effect with respect to respiratory depression. And as you can see on the right, as dose increases for buprenorphine, which is the partial agonist, the percent of maximal effect on the y-axis, which is respiratory depression, hits a plateau. It also has high affinity, meaning it binds tightly with the mu opioid receptor, which makes it compelling in terms of its long-term analgesic effect. It was actually originally developed as a pain medication, and there are multiple formulations of it available on the market, and I will simplify this somewhat to say the high-dose formulations are FDA approved for opioid use disorder, and the low-dose formulations are FDA approved for pain. And if I could make one suggestion from a policy standpoint, if we could get the high-dose formulations approved for pain, we would do a lot of good for our patients. So buprenorphine has, and sorry, I just need to move my toolbar so I can see my slides, has compelling advantages for use in the co-occurring chronic pain and opioid use spectrum. So first of all, it treats physiologic dependence. So people who are taking opioids either illicitly or by prescription over time develop physiologic dependence. It may improve pain control compared to regular full agonist opioids. And compared to full agonist opioids, it may reduce what I call opioid burden, just sort of the constellation of symptoms patients may experience, like sleepiness, sedation, fall risk, and it will also reduce overdose risk. So I wanted to tell you about a study briefly that we engaged in starting in 2017, the Veterans Pain Care Organizational Improvement Comparative Effectiveness, or VOICE trial, funded by the Patient-Centered Outcomes Research Institute. PI was Aaron Krebs, and I and Karen Seal were co-PIs. So this was a study in 10 VA sites. 207 veterans were enrolled in this. This was the second aim of the trial. I'm not going to discuss the primary aim, focusing here on the second aim because that involves buprenorphine. So 207 patients who are receiving at least 70 milligrams morphine equivalent daily dose. So moderate to high dose opioids for treatment of moderate to severe chronic pain, who were followed for 1 year in a collaborative care pain treatment clinic. And they were randomized to individualized advice on tapering, if appropriate. And they were in that advice either to engage in a standard taper, which included patient-centered motivational interviewing, framing the taper as what they could gain from it, reassurance that they would be partnered with in this process, and then taking a slow stepwise decrease in opioids while bolstering other non-pharmacologic and pharmacologic treatments. The other group was randomized to optional buprenorphine. And in this group, patients were discussed the option of receiving buprenorphine as an alternative to stepwise taper down. Per protocol, patients were to hear about buprenorphine within the first 9 months of the intervention. Also were accompanied with a gain framing message. What could they gain by switching to buprenorphine? And reassurance that any decision that was made, they could reverse their decision and the team would work collaboratively with them. They were given a protocol for how to start the buprenorphine using the overlap method. And as with the standard taper group, were other treatments were bolstered. So, well, results are study participants at baseline. You can see average age of 61, veteran sample, so predominantly men, but 14% women in the buprenorphine group, 80% white. And as you can see, daily opioid dose in the two groups was around 160 morphine equivalents, and their BPI total score was around 7. So almost severe pain at baseline on average. And I'm not going to walk you through each cell of this slide, but I will summarize quickly to say on the primary outcome of change in brief pain inventory, so improvement in pain, both the standard taper group and the optional buprenorphine group were the same. They both improved about half a point on the BPI. And similarly, in the opioid dose outcome, which was the secondary outcome, both reduced about 60 milligrams morphine equivalents, and statistically speaking, they were the same. So the key take-homes from this study, which were that optional buprenorphine did not improve pain and did not lead to larger opioid reductions compared to not offering buprenorphine. However, only 27 of the 104 who were eligible to switch to buprenorphine did. So that low rates of switching probably limited our ability to detect a difference. And based on what we learned from this trial, future studies should be more buprenorphine forward. And by that, I mean, the interventionists who are recommending buprenorphine should do so probably from the first meeting and should be probably intensively trained in how to make that suggestion very explicitly and confidently. There was a lot of variability in how many patients were actually offered buprenorphine, suggesting there were some non-confident recommendations of it. Last thing I'll mention, 9 out of 27 individuals who switched to buprenorphine ended up switching back to full agonist opioids. And this did raise a question in our minds, is there a role for combined buprenorphine and full agonist opioid regimens? So with that, I will turn it over to Dr. Bonnert.
Well, if you want to keep advancing the slides in the interest of time rather than switching over, so maybe people will be seeing your face and my voice, but it'll, I think, okay. Oh, look, I got added. Hi. So I'm Amy Bonnert, professor of anesthesiology and co-director of the Opioid Research Institute of University of Michigan. I'm going to talk about a study that I think is a real complement to the voice study in a lot of ways. And hopefully between these two, both studies are, Will and I are both presenting results that are not published yet and hopefully give a sense of where things should go next ahead of waiting for those publications to come out. So for this study, which is the contact PI is my colleague Pooja Lagasetti. I am co-PI with her on it. We are using VA, and Will is involved as well. We are using VA medical records data with two purposes. First, and actually there's qualitative interviews. I didn't include that. We haven't started them yet. The two purposes I'm going to talk about are to identify a cohort of patients on long-term opiates and figuring out how we can extract from medical records data if they fit in this gray zone of not having meaningful criteria for an opioid use disorder, but having some aberrant opioid use, opioid misuse, whatever you want to call it as well. And then the second is to do target trial emulation of comparing 3 different treatment options. We looked at continuing treatment relatively unchanged, tapering, and rotation of buprenorphine. Next slide. So for that first step of can we identify opioid misuse, we were building off of some previously completed work led by my colleague Victoria Powell, where we used a structured chart review abstraction tool to look at opioid use disorder symptoms in notes. This is among patients who had an ICD diagnosis that was related to an opioid use disorder, but as some people may be familiar, the ICD codes don't actually really map on exactly to how we think of opioid use disorder. There's an opioid dependence code that's very vague. So not surprisingly, you can pick up on once you do a chart review, you realize there are people with these codes who do not have what we think of as an opioid use disorder. That's only about 62% of the sample, and about 18% fits into that that gray zone type level we're interested in here. Another 20% with no evidence of any misuse. Next slide. So that method of doing a detailed chart abstraction, it's good to know that it works, but that's not very scalable. So for the next step, we are using elastic net regression to make that process scalable. There's a lot of results of this because you can do a lot of comparing different modeling and options. I thought the key takeaways for this workshop is that the prediction is worse in terms with patients with other serious illness. So for example, people with palliative care codes, the elastic net regression has a really hard time figuring out what group they should be in. Once you exclude down the sample a lot to a less clinically complex sample, the prediction gets relatively good with positive predictive values in the 0.9 range. But there's definitely some limitations here, which I'll swing back to on the next steps. So once we applied that elastic net regression, next slide, Will, we took the sample that we could have where we, the scaled up sample we could get through that to do a target trial emulation. Very briefly, this is a method that is an observational study method, often done with medical records data, but it improves on conventional observational study methods through a bunch of design features that, if it's done correctly and rigorously, should avoid a lot of common biases. So, for example, time anchor alignment can avoid things like prevalent user bias, can avoid a more person time. I won't get into all the details, but there's a whole suite of things that have shown that when people use these methods, the results of these target trial emulations end up much more similar to actual clinical trials that were conducted than observational studies that have not used those methods. It also avoids selection effects of who enrolls in a trial, which I think will become apparent why that's important in a second here, and also you can get much larger sample sizes. So the primary outcome we looked at was also pain intensity. So these were NRS scores entered into the medical record. We did not collect them. They were already there, but as people are probably familiar, when you go to the doctor, you get asked it a lot. So we had pretty good completion rates on this. And we compared their pain scores over 6 months of follow-up to their pain scores in the baseline 6-month period. Next slide. So here are our key results of that target trial emulation study. Once all of those selections were applied, we end up with 2,916 people through the elastic net regression, our sample here of people with opioid misuse and who were prescribed opiates for chronic pain. So what we found overall is that the people who changed to buprenorphine in those 6 months had greater reductions in their pain scores compared to people who were treatment as usual on their full opiate agonist. We also looked at tapering, which the definition here was about an average of a 10% decrease per month sustained for 6 months, but did not require discontinuation, which is sometimes confused with tapering. We found no difference in pain outcomes for tapering compared to treatment as usual. So neither improvement nor worsening in pain. You can see the estimated effect size there is very small, so I don't think it's a power issue. We we were concerned about the fact that people who were rotated to buprenorphine had higher pain scores on average at baseline. So we also looked stratified by low, moderate, and baseline pain levels of being high, moderate, or low. And it looks like the effect was most concentrated in those with the high baseline pain. So in other words, people who had quite high pain at baseline benefited the most from switching to buprenorphine compared to if they had stayed on treatment as usual. Next slide. So the key takeaways from these studies: opioid misuse can be identified from medical charts, but not perfectly. We need to better understand when buprenorphine is the best option for a patient. Target trial emulation can fill some of the gaps in what's not possible to study by RCT, better than conventional observational studies, if those are the two choices. There's also some efficiency, some of the discussion we've had this morning about subgroups that have been understudied. I think target trial emulation may sometimes be the practical option for overcoming how difficult it could be to study people with relatively rare conditions. And then I have one more slide, sorry, I'm over on time, which is what about serious illness? So, just mentioned that there are people with, say, cancer as an additional diagnosis that get excluded from a lot of trials. There's much less research in general on comparative effectiveness of what to do with these patients. There's, my understanding, a lot of debate on the role of opiate sparing in this group. There's growing interest in buprenorphine, but again, probably not nearly enough quantitative data to guide practice strongly, and it's unclear how to integrate buprenorphine or other pain treatments into the other intensive therapies that patients with serious illness are undergoing, like chemotherapy. And I'll stop there. Thanks.
Thank you both. Our next presentation will be on non-pharmacologic approaches by Sarah Edmond.
All right. Hi, everyone. I'm Sarah Edmond, and I'm a clinical psychologist and pain researcher at Yale and VA Connecticut. I don't want to share what was repeat what was shared by others earlier, so I just want to briefly say that chronic pain is best seen as a biopsychosocial phenomenon and very rarely occurs in isolation. Patients with chronic pain are more likely than the general population to report substance use, including tobacco use, alcohol use, and other substances. And many people who use substances report that they do so to treat pain. Also, many people who use substances use more than one substance, and they can impact each other in a variety of ways. And a lot of people with pain who use substances also meet criteria for another mental health condition, like Dr. Cronky talked earlier about, particularly depression. So thus it stands to reason that treatment that targets the whole person and multiple concerns are needed, and behavioral treatment can be one way to do that. There are several underlying theories or hypothesized mechanisms that drive the behavioral treatments that are out there, and they are somewhat overlapping in how they're conceptualized. Dr. Dietrich earlier shared about the reciprocal model. There's also a lot of research about the involvement of the reward system and dysregulated dopamine, both for pain and for substance use disorders. And a recent review paper proposed that emotion regulation might be a transdiagnostic factor underlying both pain and substance use. Many substances are short-term analgesics, so substance use might be conceptualized as a maladaptive coping response to pain. And all of these different mechanisms and theories point to the potential value of behavioral interventions to change patterns of reinforcement, modify dysfunction in the reward system, and teach skills to modify coping responses. So the research in neurobiology really highlights the potential benefit of interventions that target stress, coping, and negative affect. And the hypothesis about emotion regulation as a transdiagnostic factor suggests that treatments that target emotion regulation, such as dialectical behavior therapy, might be effective. So I'm going to review the state of the evidence first for behavioral therapies for treating pain and substance use. Most interventions that have been studied are rooted in cognitive behavioral therapy, mindfulness or mindfulness-based stress reduction, acceptance and commitment therapy, dialectical behavior therapy, or other mind-body approaches. Big picture, there was one review paper and one meta-analysis that I found that both reported some promising results with moderate to small effect sizes. So a 2016 review paper focused on patients with chronic pain, depression, and substance use disorders, published in 2016, found 6 articles with almost 700 patients that received some sort of behavioral treatment. mindfulness-based treatment, acceptance and commitment therapy, CBT. And they had promising improvements across all studies, but moderate to small effect sizes. Eric Garland published a meta-analysis in 2019. This focused on both acute and chronic pain and opioid outcomes. It had 60 reports of 6,400 participants, and the mind-body therapies he looked at included meditation, hypnosis, relaxation, and cognitive behavioral therapy. Many of these mind-body therapies are associated with moderate improvements in pain and small reductions in opioid dose. However, the majority of the studies in that meta-analysis were either acute pain or cancer-related pain. So now we'll talk a little bit about some of the most common treatment modalities and the evidence for them. Cognitive behavioral therapy provides coping skills training to manage chronic pain and substance use disorders. And I've highlighted just a few studies below that incorporate skills from CBT for chronic pain as well as CBT for substance use disorder into their treatment protocols. As you can see, each of these studies are relatively small, although they all showed movement in the right direction of the outcomes of interest. But two of them were pilot studies that really weren't even powered to detect significant changes in outcomes. Third wave therapies include things like acceptance and commitment therapy for chronic pain and dialectical behavior therapy for chronic pain. Acceptance and commitment therapy is different than CBT in that it focuses on decreasing pain's interference on functioning, particularly with regard to meaningful activities. So in ACT, there is an exploration of values, some work about willingness and acceptance, and mindfulness is also typically a core component. Dialectical behavior therapy was initially developed to treat people with borderline personality disorder and has a large focus on skill building. Notably, one of the primary targets of dialectical behavior therapy is emotion regulation, which might be the underlying mechanism that drives the co-occurrence of chronic pain and substance use disorders. I also want to highlight that of these 4 studies I found, the second 2 didn't specifically target substance use disorders. So the VALVE study included people with hazardous opioid use, which they had a list of criteria, including mostly misuse-related behaviors. While the last study that used DBT included anybody who was prescribed long-term opioid therapy. So there's sort of a range between whether the focus is people with a substance use disorder, and in that case, those treatments tend to be delivered within substance use disorder treatment settings, or if they focus more broadly on substance use or potential misuse, in which case outpatient clinics, pain clinics, et cetera, might be where they're delivered. Another treatment rooted in third wave principles is mindfulness-oriented recovery enhancement, or MORE. This was developed by Eric Garland. MORE is a mindfulness-based intervention that targets chronic pain and opioid misuse. The treatment includes mindfulness, reappraisal, and savoring positive experiences. MORE has been evaluated in, I think, now over 10 randomized trials, although not all of them have focused on opioid misuse or opioids or substance use disorders. But there are ongoing trials that are evaluating MORE for pain and opioid use disorder in the setting of opioid use disorder treatment. So here I've highlighted just 2 of the studies. One is a large study targeting opioid misuse in primary care, and a second, more recent study that was conducted with people with OUD who were being seen in a methadone treatment clinic. And both of these studies had positive outcomes on their primary outcomes. So to sort of summarize the behavioral treatments, in general, these treatments all emphasize a psychosocial model of pain. They include a functional analysis of behavior that's focused both on pain and substance use. The models that underlie these treatments conceptualize substance use often as a maladaptive coping response to pain. Treatment includes teaching pain coping skills, so things like activity pacing, relaxation, cognitive restructuring, and mindfulness. As well as addressing mood disorders. So sometimes components of behavioral activation are incorporated into CBT for chronic pain. And there's also particularly in the CBT protocols, skills to support coping with cravings and relapse prevention. When we look at other non-pharmacologic treatments, such as movement-based treatments, there is a lot less research published. So for pain alone, we know that a range of movement-based interventions have a strong evidence base. So things like physical therapy, aquatherapy, yoga, walking programs are all good choices for chronic pain treatment. For substance use or substance use disorders, there's very little research, although there's some research suggesting that exercise might be an effective adjunctive treatment. Some research has shown that exercise might reduce cigarette craving or tobacco withdrawal symptoms and also reduce negative affect, which might be an indirect way to affect substance use. And one study showed that aerobic exercise in particular might reduce drug cravings among people with a substance use disorder. But there's even less data about treatments that target the co-occurrence of pain and substance use or substance use disorders. So there's one pilot study that examined the feasibility of offering weekly yoga in a methadone treatment program for people with pain and opioid use disorder. There's another study that sampled residential substance use disorder treatment programs. They found that about 3% of them incorporated some sort of chronic pain program into their residential SUD treatment program. And those programs had movement approaches such as physical therapy, yoga, or exercise. And then I found one study that evaluated a specific residential treatment program that incorporated movement therapies alongside other modalities for patients who had pain. And they found improvements in both pain and substance use related outcomes. So they measured pain severity, interference, tapering, and remaining on methadone. Oops. If you zoom out a little bit, there's also some emerging literature about interdisciplinary treatment models. This literature tends to fall into two categories. One is residential or intensive substance use disorder treatment programs that have a lot of different modalities involved and might incorporate things that are targeted at pain. And then there's interdisciplinary pain management programs that may incorporate some treatment that targets substance use or substance use disorders. But data supporting the efficacy of pain treatment within SUD programs is very limited. And then research about interdisciplinary pain programs has typically been conducted in integrated health systems like Kaiser or the VA, and it's focused almost exclusively on opioid use or misuse. There's been a lot less about people with a substance use disorder or people who use other substances. Also, most of the published studies in this area focus on the integration of behavioral treatments into a wider program rather than the integration of movement-based approaches, although many of them have some type of exercise or physical therapy as an optional component. Of note, VA medical centers are required to have interdisciplinary pain management teams that include expertise in pain, addiction, behavioral approaches, and rehabilitation approaches. And we don't know that much about the way addiction expertise is incorporated onto these teams, but that is a potential area for future study. Regarding prevention, there's really very, very limited work in this area that targets both pain and substance use disorder. If you conceptualize substance use or misuse as a maladaptive coping response, then prevention of the transition from acute to chronic pain and preventing pain-related disability, early intervention to teach adaptive coping skills might prevent substance use or misuse among people with pain. And similarly, we know there are early interventions to reduce unhealthy substance use that might prevent the development of substance use disorders. So a very brief overview before I talk about gaps in future directions. There have been several trials of behavioral interventions rooted in cognitive behavioral therapy or third wave behavioral approaches that demonstrate some evidence for improving pain and substance related outcomes. The majority of that work has focused on opioid misuse or opioid use disorder, and not much has focused on other substances. Research on movement-based approaches and research on prevention is significantly limited. And there are a lot of different gaps in future directions that I want to highlight. This is just sort of a sampling of the things I want to cover. The first three, I'm going to go into more details. So before I do that, I'll talk about the rest. There isn't really a lot of long-term data on any of these studies. Most of them, particularly the pilots, looked at just pre-post or a couple of months out of treatment, and the longest length of follow-up I could find really in any of these studies is 12 months. So there isn't a lot of data about the sustainability of treatment gains. And since both chronic pain and substance use disorders are often talked about as chronic illnesses, understanding the trajectory of what happens over time is really important. Regarding movement-based interventions, while there is a little bit of work in substance use disorder treatment settings, and that work has suggested that aerobic exercise helps cope with craving, There's other research focusing on a mind-body approach such as yoga, and it's not clear what would be the mechanism driving whether something like aerobic exercise or yoga would be more effective, or whether there might be different groups for which one is more effective than the other. Additionally, with interventions such as CBT-informed physical therapy and pain neuroscience education, as well as CBT protocols that incorporate movement, there's an increasing overlap in the delivery of behavioral and movement-based interventions for pain. So understanding how those work or do not work with people who use substances or have substance use disorders is important. Also, ideal treatment for chronic pain is integrated, interdisciplinary, and multimodal. And most research on these integrated models don't include people with substance use disorders. There is some work that incorporates people who misuse opioids or have concerning opioid use. That's mostly done in the VA or other large integrated systems. So we need more research to understand first how to incorporate substance use disorder treatment into interdisciplinary pain care, and then also how best to translate those interdisciplinary pain models that are working well outside of the VA and into other systems. There are also many intensive and residential treatment programs for substance use disorder, and only a small percentage of them incorporate pain treatment. So that's another area for future work. Finally, I don't want to reiterate what others have shared earlier about social determinants of health and health disparities, but because there's only a handful of trials for behavioral interventions for co-occurring pain and substance use, and many of them had a small number of participants, there's not a lot of evidence about which of these treatments work for whom or how the social determinants of health might impact treatment outcomes. Next future direction is sort of implementation and treatment considerations. A lot of work is needed to figure out how best to make the treatments that do work more widely available and accessible. CBT for chronic pain on its own is not widely available, and there are a lack of trained clinicians. And similarly, instructors that are trained to do movement-based interventions such as yoga or physical therapy are not widely accessible in all areas, and they're unlikely to have any additional training in substance use. So identifying clinicians who can deliver integrated treatments is likely a barrier to making those treatments accessible. Many of the research studies I cited today use PhD level clinicians, although there have been a few that have made efforts to train people who work in addiction treatment settings. And more work is needed to figure out who's able to deliver these. Most of these, I think I already talked about long-term outcomes. Sorry, I see I'm over time now. There's also not much work in terms of co-occurrence of multiple substance use disorders or incorporation of treatment of mental health disorders. Many people who have chronic pain and use substances also report symptoms of depression. Some parts of CBT already incorporate skills that might target depression, but more work is needed here. Also, many of the studies we reviewed focused on opioid use or misuse rather than opioid use disorder per se. And the way studies operationalize opioid use, misuse, and opioid use disorder is highly variable, and that makes it really difficult to compare across studies. And I think I'm out of time, so I'm trying to skip through, but the field really lacks consensus on this topic, and finding a way to make sure we're sort of using the same language and criteria when talking about this is important. So I wanted to highlight that the New England Journal of Medicine recently published an article about the prevalence of iatrogenic opioid use disorder based on a change in methodology in the National Survey on Drug Use and Health. And the way that we think about assessing for opioid use disorder among people who are prescribed opioids and do not misuse their opioids is also an important area to consider in the future. Finally, we focused a lot on opioids. They're extremely important, but pain co-occurs with lots of other non-opioid substances. There's a handful of studies about tobacco cessation, but they find that people with pain quit at much lower rates. Rates of alcohol use among people with pain are high, and there's not a lot of work there.
I think we're going to have to leave it there. Thank you so much. Now we are going to have a discussion of those last two presentations led by Hector Perez.
Hi there, and good afternoon, everyone, and thanks to the doctors Becker, Bonart, and the admin for their great presentations. I'm Hector Perez. I'm a general internist and physician scientist at the Albert Einstein College of Medicine. I conduct clinical trials in pain and substance use, with particular interest in mitigation of opioid use through behavioral and other non-logic approaches, which include ACT, virtual reality, and acupuncture as well. Turning to questions, so there was quite a lively conversation in the chat. The first question I want to ask is from the Q&A. So the question is regarding the prescribing. The definition seemed to vary from complete cessation to step down approach / dose reduction. For the PPI literature, moving to an H2RA is considered the prescribing. Do we think moving from full agonist opioids to buprenorphine is consistent with the spirit / definition of the prescribing?
Yeah, that's a great question. I'll take a stab at it. So, right, I mean, when I think about interventions in patients who are prescribed opioids, it's clinically, has their pain improved? And that's what patients tell us is the most important outcome for them. And then secondarily, has their safety improved? And I think that's what we're attempting to do with deprescribing. So if we can show improvement in pain, decreased pain, and improved safety, we have, I think, achieved a good outcome. So that might mean full discontinuation of opioids, but I think it's also fair to say a dose reduction or a switch to buprenorphine would also count as moving in the direction of safety. But I'd love to hear what others think.
No, I think that's a good summary, Will, but also being consistent and having that expectation across the different treatments you could consider switching to, right? I think sometimes there's just focus on safety or just focus on pain and holding all of the options to the same standard.
Yeah. Along with that conversation, in the chat as well, there was a conversation about speculating about reasons why people in your trial will switched back. I think in talking about the prescribing, it might be helpful to clarify that. What were some reasons?
Absolutely. And I will say, you know, each aspect of this trial was, you know, patients were engaged in shared decision-making. There was nothing, you know, everything was optional, essentially. If they were randomized to hear about buprenorphine, it was an option whether they decided to switch to it. And then they were told, if it isn't working out, and you're not satisfied with it, we can switch you back to full agonist opioids. And that's what happened in a third of the 27 who switched. I mean, I think we would say, you know, clinically, we say if you go to buprenorphine and you're on it for 2 to 3 weeks, you've essentially, you know, this is not my favorite term, but detoxified from your full agonist opioid. So if we are to switch back to full agonist opioid at that point, we need to do it at a much lower dose because you have lost your tolerance to full agonist opioids. So even by going through the switch process, going back to full agonist opioids, they, in most of the cases, have reduced their dose and may even find it more effective at a lower dose. So potential good outcome there as well.
Shifting topics over to the non-pharmacologic presentation. Sarah, in your opinion, what are some potential areas, some potential gaps in research that could solve this problem of treatment access? You've presented a substantial amount of data on trials in both therapies, movement therapies, and other non-logic approaches. And I think that treatment accessibility, despite the substantial evidence base, is a major barrier.
Yeah, thanks for that question. I think, one potential avenue is to evaluate who is able to be trained in some of these therapies. I think a lot of the research is focused on people with PhDs and advanced degrees, lots of experience. Are some of these therapies appropriate to be delivered by other types of clinicians? I think there are probably some patients for whom asynchronous treatment or virtual treatment is likely to be effective, understanding under what circumstances people might be appropriate and benefit from those treatments, and then either offering synchronous treatment virtually so that people in areas without clinicians who are trained can receive treatment, or thinking about digital platforms that are asynchronous or require less provider time is another important future direction. I had one other. Lost. Oh, I also think that one of the themes I saw in the chat earlier is that is it really any of the specific interventions or therapies, or is it a relationship with a trusted clinician who really listens to you that's driving the effect? And I would say that I think it's both. I mean, I'm a pain psychologist, so I think that the interventions we do have value, including the relationship we build with patients, but above and beyond that. But to the extent that relationship building and a trusted clinician is an important aspect of treatment, can we think about things such as peers and peer specialists as a way to enhance the accessibility of a person who's supportive and listening on the treatment team?
I want to actually follow up on that question with a question in the Q&A. Stefan wrote, there are plausible benefits for many therapies presented, ranging from ACT to BUP. I would suggest some strategic focus on what we would call contextual elements, factors that influence a patient or family decision to engage or adopt a treatment, the patient's calculation of whether the treatment will be worth their while, the factors conducive to gaining by the treatment in daily life, and the clinical and family relationships that favor the long-term benefit.
Yeah, thank you for that question, Stefan, or suggestion, I guess. I think that's right. I think understanding the whole person is an important part of deciding what treatment is the best fit, and a shared decision with the treatment is important. I know in our clinic, psychology is sort of built into the intake of pain assessments when you first come to our pain clinic. And we do that intentionally so that everybody gets exposed to the idea of behavioral treatments being a potentially valuable part of a treatment plan, sort of in an effort to destigmatize and also demystify like the idea of like, why would I talk to a therapist about my pain? And I think doing that and building relationships and then working with patients to make a decision about treatment that fits their lifestyle in terms of their ability to travel or come in or how frequently they want sessions, but also in terms of their functional goals. Are they more focused on being able to walk around or move more? Are they more focused on engaging in valued activities that don't require a lot of mobility? Those kinds of things can help you guide them to what treatment might best fit their needs immediately.
Can I just add, what you just said and Stefan's comment, for me, it triggers a thought. We've been thinking some on this group also about precision medicine and kind of the intersection between figuring out what treatment is someone going to get the most benefit on based on their characteristics and patient preference, and how do you combine those two together, I think will be really important. Just with the wide array of potential treatments here, which is a good thing, right? And even more treatments would also be good, but how do we pull that together will be important.
Yes, certainly. And I think in addition, not only that, but in clinical trials, implementing choice as well. As you actually mentioned, Will, in your trial, you implemented choice, and it allowed us to see how patients valued the intervention. I had a separate question which was related. So there was some talk in the chat about some of the differences in the results between Will's study and Amy's study, and there was some talk about whether or not people had the options to choose. Can you elaborate on that?
Sure. Yeah, I think, Will, you elaborated some in the comments, so I can add for the observational study, everybody who we are considering on buprenorphine actually, filled at least one prescription for buprenorphine, right? And that's a big difference between a clinical trial where what someone was randomized to in an observational study. I did go back and check the code book after seeing those questions and confirm that the way we defined it was at least one fill of buprenorphine. So, which is not a high threshold. It probably maps onto reasonably well of like that decision of, okay, let's start buprenorphine. Some people continue it, some don't. That's kind of what we're measuring there, but nobody who just chose not to take it at all. Will, did you want to further comment on voice with it?
Yeah, I mean, as I mentioned, they got the option. All patients randomized to the buprenorphine option got just that, but how it was framed, we had 10 sites. The study's primary focus was randomizing to 2 different care models, and many of the folks who were, they were focused on their role in those 2 care models and not as focused in how to quote unquote pitch buprenorphine. And we saw a high variability, one site, 0 out of 16 eligible patients switched to buprenorphine. And at our site, 8 out of 10 eligible patients switched to buprenorphine. So clearly there's variability in what patients are hearing and probably the comfort level of the person making the recommendation. Right.
I actually realized that we have about a minute left, so I'm not sure that we can answer this last question. However, I will ask it. What is the theoretical framework for personalizing care out of 100+ choices? What is the minimum needed interventions, etc.? Or should we have a theoretical framework?
Hector, for time, would it be okay if folks answered that question in the chat?
Of course, yes.
Okay, perfect. All right. Thank you very much. We're going to move on to the next session. All right. So our next presentation will be about non-opioid substance use that complicates pain, and that will be presented by Joe Dietrich.
All right. Hi again, everybody. Just very quick introduction in case you didn't get the first one. My name is Joe Dietrich. I'm a professor at the Department of Psychology at Syracuse University. I'm a clinical psychologist, and I'm going to be talking about non-opioid substance use. As soon as we get it, there we go. I don't have any disclosures. So a very brief outline of this brief presentation. I'm going to delve a little deeper and unpack some of the bidirectional effects in pain and substance use, allude to some of the guiding theoretical perspectives, talk about nicotine and tobacco and alcohol in turn, and then close with a focus on research gaps and future research directions. So we presented this earlier and talked about it some, but unpacking these directions a bit further, we start with the effects of substance use on pain. And some of the earliest work done in this area focused on acute analgesic effects. So alcohol, tobacco, and other substances over the course of time and via meta-analysis have been shown to demonstrate acute pain inhibitory effects. And this is really important when thinking about some of the reinforcing properties of substance use in the context of pain, which was alluded to just a short while ago. Another really interesting topic to me in this area is abstinence-induced hyperalgesia. So this is addressing the question of what happens when people with chronic pain who use these substances regularly or heavily stop using them? What happens to their pain experience and their pain trajectory? So abstinence-induced hyperalgesia refers to the near-term increase in pain sensitivity or experiences of greater pain intensity, which by themselves are problematic from a substance use treatment standpoint in terms of potentially precipitating relapse. And of course, the longest standing work in this area is the heavy and prolonged use of substances serving as a unique causal factor in the development of chronic pain. Now, unique causal factor means after accounting for many other factors that drive the onset of chronic pain. And this has been linked strongly in some conditions relative to others, but is another area where more work needs to be done in terms of extending it to other chronically painful conditions. If we switch gears to the other direction, the effects of pain on substance use, again, this is some of the more recent work where the question was, to what extent does the experience of pain potentially drive or serve as a proximal antecedent of substance use? Consistent with that is that people with chronic pain readily endorse the use of these substances to cope with their pain experience. And for many of them, identifying it as a primary coping strategy, which of course may negatively impact the utilization of more adaptive pain coping efforts. There's also increasing evidence that the experience of pain serves as a significant barrier to reducing substance use or abstaining or ultimately ceasing such use. And finally, in part via this reciprocal cycle, increased risk for developing substance-related disorders. There's been some conversation here about the difference between substance use and substance-related disorders. And I think it's helpful to think about that on a continuum. In some cases, substance use is producing acute analgesic effects, but perhaps over time, you experience increased opportunity to develop a substance-related disorder. So when you put these separate directions together, you get this bidirectional model, which is thought to operate in the manner of a positive feedback loop that ultimately leads to the maintenance and progression of both pain and substance use. In transitioning to thinking about some guiding theory in this space, one that's helpful to invoke is the allostatic load model of pain and addiction, which in essence posits that chronic substance use can ultimately dysregulate these overlapping neural substrates and homeostatic pain mechanisms to engender a persistent imbalance that favors pain facilitation. So over time, enhancing pain and imbalance towards a pain experience. Now, there's many mechanisms by which this might occur. Several that have been suggested include central sensitization, altered neurotransmitter systems, and neuroinflammation. If we turn our attention to the effects of pain on substance use, one of the thoughts here is that these repeated pairings of the experience of pain and the use of substances over time can come to condition pain as a cue, that over time it can come to trigger excessive incentive motivation that leads to alcohol and drug seeking and ultimately relapse. And this is highly consistent with negative reinforcement and self-medication models of addiction motivation, which some other presenters have referenced already today. If we turn our attention to the topic of pain and nicotine and tobacco, a lot of these rates map on to the comorbidity presentation of earlier, and there's lots of ways to slice this data, but I would say the short version is that while there's been a real decrease in the use of, for example, combustible cigarette smoking over the course of time, the same degree of decrease has not necessarily been observed among people with chronic pain. In fact, in the general population right now, we're hovering around 12% current cigarette smoking use. And in nationally representative surveys, we see those numbers jump to the 30%-ish range, again, depending on the condition and the setting in which those data were collected. And then the final bar that you see here is clinical pain. So this is people who are seeking treatment for their pain, where we see rates of smoking even higher. So again, there's a kind of a notion that cigarette smoking is becoming less of a thing. But for those of us that work with individuals who have pain, our observations tell us that's not necessarily the case. In terms of the state of the science in this space, if we compare current tobacco smokers versus non-smokers, those who use cigarettes tend to report more severe pain and more severe functional impairment. And this is observed across painful conditions, including in the context of cancer, where more work needs to be done. They also tend to use more opioid medication, even when self-administered post-surgically. If we compare nicotine tobacco users with pain to those who don't have pain, we find that they tend to smoke more, but now they're also more likely to co-use e-cigarettes, perhaps as a way to supplement their nicotine intake throughout the day. Tobacco users and nicotine users with pain tend to be less motivated and confident in their ability to quit. They're less likely to initiate a quit attempt. They've been shown to experience this withdrawal-induced hyperalgesia that I talked about before, and they're also more likely to lapse and relapse following a quit attempt. If we switch gears to the topic of pain and alcohol, we see a similar distribution, although the organization of it is a bit different. So each bar here represents current drinkers with varying levels of problem or hazardous drinking. Different terms are invoked in this literature. And here is depicting the percent who endorse moderate to severe past month pain. So among non-problem drinkers, you see around 30%. For problem or heavy or hazardous drinkers, we see around 43%. And again, those seeking treatment for alcohol use disorder, we see some of the highest rates of pain endorsement. State of the science in this space is that those who use alcohol and have chronic pain, of that group, about 28% report using alcohol to cope with pain. They are 2 times more likely to meet criteria for an alcohol use disorder than are drinkers with no pain. And again, we see evidence, initial evidence at least, of withdrawal-induced hyperalgesia, so increased pain sensitivity following abstinence. Another important and concerning aspect of alcohol use is co-use with opioid medications. And this is of interest because alcohol is known to increase the analgesic, the reinforcing, and the sedative effects of opioid medications. And among people with chronic pain who are prescribed opioids, about 20% report concurrent or co-use or overlapping use of alcohol and opioid medications. Collectively, this interferes with treatment and produces dangerous and potentially fatal health effects. So let's close out with a focus on specific research gaps and future directions. I suggest we need an increased focus on co-use of substances in general. It's very convenient and clear at times to focus on dyads, pain and a given substance. But for people that live and do work in the substance use area, you know that co-use of substances is actually quite common. So we really need to extend this work to substance co-use. We also need to look at substances, other ones that are commonly used in the context of pain that are just starting to gain attention in this area, like benzodiazepines and stimulants. It's also important that we move beyond pain intensity. A lot of our work focuses on the severity of pain experience, but we're finding a lot of signals when we look at data related to disability and functional impairment. So more attention to those is suggested. We had a great presentation on psychological and behavioral health comorbidities. This further complicates the picture, but to move this literature, this area forward, we really need to look at comorbidities and co-occurrence of things like anxiety, depression, PTSD, and even insomnia, which has been linked to both pain and substance use separately. We also had a great talk on social determinants of health. I'd like to highlight what some call psychosocial determinants. So that's the lived experiences related to stigma and discrimination. And also commensurate with that, an increased focus on health disparities populations, including those noted by NIH, but also veterans where you see higher rates of both, and people with disabilities, which is really interesting because NIH just added that in the past year to their list of health disparities populations. And depending on how that's assessed, highly relevant to the context of chronic pain. We also need greater treatment development in RCTs, which have been discussed. I'll just add that integration includes both the content, so addressing both at the same time, and or the setting, so implementing pain treatment in the context of substance use and vice versa. And several of my favorite social cognitive and transdiagnostic factors have been mentioned, but these are highly relevant to intervention development and also understanding these pathways, expectancies, perceptions, self-efficacy, and et cetera. There's a lot of work coming out about these, and it might be a useful way to target both conditions simultaneously. Lastly, of course, we need more rigorous methodology, experimental studies that clarify mechanisms, longitudinal studies that get at temporal precedence, and ecological momentary assessment to get at those granular data. Thank you, and we look forward to the next presentation.
Thank you. Our next presentation will be about pain management with non-opioid substances that have an addictive potential, given by Aziva Cooper.
Right. So I'll go ahead and share my screen. So it's really wonderful to be here today. I'm going to be talking about a little bit of a different direction with respect to substances that are emerging or have been around for a very long time, but are becoming more popular in use and have a signal for misuse potential. And they're not FDA approved, but they are being used to help with both chronic pain as well as substance use disorders. And so the drugs I'll be talking about today are cannabis, ketamine, and kratom. So some disclosures here. My work is funded by the NIH and California State. So a brief overview of what I'll be talking about today is I'll describe the regulatory status and access to these three drugs, cannabis, ketamine, and kratom. I'll talk about what we know with respect of the use rates and evidence for analgesic effects of these three agents, and use rates and evidence for their use for SUDs, substance use disorders. And then I'll talk a little bit about their abuse potential or misuse potential and the unknowns and public health priorities. So first, let's talk about cannabis. Cannabis is legal in nearly all states in the United States for medical purposes. It's also legal for non-medical purposes in 24 states. An additional 9 states allow the use of cannabis with low levels of delta-9 tetrahydrocannabinol, the primary psychoactive and intoxicating component of the cannabis plant. Despite the fact that it's legal in most states in the United States, cannabis is federally illegal. So cannabis here means cannabis with more than 0.3% THC. And it's complicated because each state has different laws governing the products that are available, governing the medical indications for which participants or patients can be recommended the use of cannabis. And there's really no unifying body that regulates the production or sales of cannabis and cannabis-derived products. So different states have different regulatory criteria, but it's really a patchwork of regulation across states, which has led to reduced integrity of products, knowledge with respect to what's on the labels, and also just overall clinical and patient education in this respect. If you look at multitudes of surveys and with asking people who are using medical cannabis, what's the reason they're using it? Pain is usually the primary condition for which people are using medical cannabis, and it's a qualifying condition in all states that have legal medical cannabis. And in 4 states, opioid use disorder and substance use disorder is a indication for which people can get access to medical cannabis. Now, all that being said, again, cannabis is still Schedule 1, and it's not FDA approved for pain or substance use disorders. And the FDA approved cannabinoids, which are the THC dominant ones, such as dronabinol and Syndrose, and drugs like that, Nabilone, as well as Epidiolex, which is CBD. Those 4 FDA-approved drugs are not approved for pain or for substance use disorders. So we have a great deal of availability of cannabis products, and people are using them for pain and substance use disorders. And so we have an emerging market across the United States. People are using cannabis in a variety of different ways, and cannabis, the plant itself, has hundreds of different chemicals, 2 of which we know most about is THC and CBD, but there are other cannabinoids, other chemical constituents that are popping up on the market that people are using for medical purposes or to kind of alter the non-medical use of the plant. So we know, again, pain is the primary reason for medical cannabis use. And if you look at states that have access to medical cannabis, 30% of chronic pain patients in those states report using cannabis for their pain. We know that there's quite a bit of evidence, as discussed before, suggesting that THC and THC-like drugs might be helpful for certain types of chronic pain. And we also think that there are other cannabis constituents that may also be helpful, but we definitely need more data. So a lot of people are using different types of cannabis products that have different amounts of other chemical constituents because they think it might be helpful for pain, although the jury really is still out with respect to evidence demonstrating that those other cannabinoids might be helpful for certain chronic pain conditions. With respect to substance use disorders, it's actually kind of difficult to find data demonstrating the percent of the population who use medical cannabis to really target substance use disorders or opioid use disorders. There was a really nice study in the state of Massachusetts that has legal cannabis sales demonstrating that 41% of patients in buprenorphine treatment for OUD had used cannabis in the past 30 days. Although it's unclear if they were using cannabis specifically to help with opioid use disorder or if they were using cannabis for non-medical purposes. In other surveys, smaller surveys, 5 to 27% of people surveyed report using medical cannabis for substance use disorders, whether that was for opioid use, alcohol use, tobacco use disorder. And if you look at the literature, there does seem to be signals suggesting that THC and THC-like drugs might be helpful to reduce withdrawal from certain medications for certain substances of abuse, including opioids and cannabis itself. And there are other cannabis constituents, for example, cannabidiol, that might also provide a signal to be helpful for substance use disorders. However, if you look at data across, using national surveys, what you find, and this was what was reported before with other agents, in states that have legal or non-legal cannabis, you see this is the prevalence of cannabis use disorder among people with pain and those without. And you can see that as a function of cannabis legalization, regulation, access, people who report using cannabis for pain have higher rates of endorsing certain symptoms of cannabis use disorder compared to those without pain. So there are a lot of unknowns here. We don't have a real good picture of patterns of cannabis use for pain and substance use disorders. As I described before, there's a lot of emerging products, a lot of different cannabinoids that are being used on the market right now, and we don't necessarily have a good handle of what the percentage is of people who are using medical cannabis specifically for substance use disorders, and that overlap of people who have chronic pain and also have substance use disorders. We know that problematic cannabis use might be an issue when using medical cannabis, especially for pain. We're not quite sure yet how withdrawal from cannabis might contribute to continued use of cannabis, and whether that might lead to greater severity of cannabis use disorder, or whether that actually might lead to use of other substances. And so we have a lot of unknowns here with respect to the safety of these products, the efficacy of these products for both chronic pain as well as to help with substance use disorders. We have a great deal of product diversity, and also trying to understand the impact of these products in at-risk populations. So we heard a little bit about older adults who are turning to cannabis more and more for chronic pain. Some of them might have a history of substance use disorders, which might increase their risk for developing cannabis use disorder. Next, for ketamine, ketamine is Schedule 3, unlike cannabis, which is Schedule 1, or cannabis with more than 0.3% THC. And ketamine is FDA approved as an anesthetic specifically for diagnostic and surgical procedures. So it is not FDA approved for chronic pain. And then there's S-ketamine, which is a nasal spray, and it's FDA approved for treatment-resistant depression. There's a growing interest in the use of ketamine for chronic pain, and this is marked by compounded products that you'll see on the internet or at clinics. There's also increased access to clinical care through telemedicine and at-home administration of ketamine. So ketamine, when used as anesthetic for diagnostic and surgical procedures, is usually intravenous or intramuscular. But now there are products out there that can be compounded, that can be used at home. And there's a great deal of off-label use as well. And so here you can see ketamine for IV and IM administration, and there's products that can be oral disintegrating tablets or be put under the tongue, as well as lozenges. So again, there's no FDA-approved indication for the use of ketamine for chronic pain or substance use disorders, despite the fact that it is being used for these indications. We know that ketamine use is increasing, and this is just as an example of how ketamine is proliferating or becoming more popular. This is recent studies by Joey Palomar, who demonstrated that ketamine seizures are increasing in the United States, as well as ketamine poison control cases. And I want to point out here that this doesn't necessarily indicate that these are related to medical use of ketamine. This is in general ketamine use. So if you look at the evidence suggesting that ketamine might be helpful for chronic pain, there is a positive signal. There have been a number of placebo-controlled studies looking at intravenous ketamine for chronic pain, and it does seem to have a favorable safety profile. But remember, this is done under observation with clinician care. It is not those telemedicine take-home doses. Less is known regarding oral and intranasal routes of ketamine for pain and those take-home medications and specific populations, especially those who have substance use disorders. With respect to ketamine use for substance use disorders, there has been a couple of studies that have demonstrated that ketamine might actually be helpful for cocaine use disorder, opioid use disorder, as well as alcohol use disorder. But there have been some signals suggesting that ketamine use disorder symptoms are exhibited in people who are using ketamine therapeutically. And if you look at the population, again, this was a smaller study in people who weren't necessarily using ketamine for therapeutic purposes, but in people who report using ketamine more than 5 times a year, it's been suggested that 30% of those people endorse symptoms of ketamine use disorder. And so for ketamine, we have a number of unknowns, again, very similar to cannabis, safety and efficacy of these different ways that people are using ketamine, the product diversity, and at-risk populations. And next, we'll move on to kratom. Kratom is derived from a tree that is native to Southeast Asia, and it's available in powders, pills, extracts, and leaves that are usually used as a tea. This is not scheduled in the United States, so it's not Schedule 1, but it's also not regulated. And so although these products are available in smoke shops, and you can see here in the United States, this is a description of how many smoke shops in each state had these kratom products. And you can see that only 5 states have banned kratom products, that they are readily available across the United States. And so why do people use kratom? In 2020, there was a really nice study that came out of Johns Hopkins. Close to 3,000 people were surveyed. And the reasons for use were pain was the primary indication for use, anxiety, depression, and about 50% of the population reported using kratom for opioid dependence. And these respondents cited withdrawal as a side effect of kratom use, and about 10% met criteria for mild substance use disorder. So it seemed like people were using kratom and that there were some adverse effects, especially related to potential use disorder of the drug itself. So it's used for pain, anxiety, depression, and substance use disorders. But again, it is not FDA approved for any indication, and it's not approved as a supplement or a food additive. A more recent study out of Johns Hopkins looked at close to 400 people who were using kratom, and they found that pain and substance use disorders, specifically opioid use disorder, were the main motivations for use of kratom in that population. And when asked about certain symptoms related to a kratom use disorder, which is not a DSM-5 disorder, but they asked about the general symptoms related to use disorder, and participants endorsed symptoms of withdrawal, craving, using kratom to avoid withdrawal, so on and so forth. So we know kratom is used for pain and substance use disorders, but kratom has not, the way that it's used hasn't really been systematically assessed. And we know very little about the potential benefits, the potential effectiveness, as well as adverse effects of kratom. There haven't really been RCTs related to kratom for these different indications. And again, the unknowns are very similar for cannabis and ketamine. We don't know the safety, efficacy. There's a great deal of product diversity now. We don't know the effects of those different products and the effects in at-risk populations, specifically those with substance use disorders. So when looking at the unknowns and public health priorities related to these 3 drugs, these are not regulated products that are available. We think that they're used on a wide scale for pain and substance use disorder, but we definitely need better surveillance. Their therapeutic potential, we're in need of RCTs of the types of products that are available and that people are using. And the unknowns, I've already described them, but we are in desperate need for understanding how people are using them, what populations are using them, the adverse effects that people report, and motivations for use. And with that, I'll end. Thank you so much.
Great. Thank you so much, both of you, Dr. Ditra and Dr. Cooper. Really appreciate that. Now we have about 15 minutes to discuss these couple of presentations, and we do have some questions in the chat, so I'm going to kick us off. This question's for Joe. Admiring your work. The International Classification of Headaches has a diagnosis of substance-induced headache and subcategories. Should chronic pain terminology have a substance-induced chronic pain and subcategories? So moving beyond headache to think about other types of chronic pain. And do you think that will happen anytime soon?
Yeah, that's a great question. I'm not specifically familiar with those criteria, but it sounds like they're talking in an acute way, such that substance use would be proximally linked with the onset of a headache. Now, there is chronic headache and migraine, which has been linked with substance use, specifically tobacco smoking, to the best of my recollection. So I think, number one, it's important to distinguish which time frame we're talking about, because that could have relevance for the type of research study that's conducted and potentially any intervention. But I can answer affirmatively to the notion that chronically painful conditions, recurringly painful conditions that have been linked with substance use, likely prolonged substance use, should increasingly be identified, not only because they warrant future study, but because that substance use may be contributing to the maintenance and continuation of that kind of pain. So I think from a pain perspective, it's clinically relevant. And one of the great things about a workshop like this is those of us who might work in the respective areas of pain or substance use aren't necessarily feeling like we're in a position to address these things. We may not have all of the knowledge. So greater collaboration on these topics is the best way forward, I think, regardless of condition, whether that's different types of chronic pain or different forms of headache. Thanks.
Thank you. Okay, there's a question. How would cannabis or any substance, I think this is for you, Ziva, be conceptualized and managed as a treatment within the reciprocal model of substance use and pain? What would be the target of treatment? What would be the ideal duration, etc.? So either of you can answer that.
I'll pass.
I'll start off with saying, so part of the complexity that when talking about cannabis, and cannabis specifically, is that, it really depends on what it is we're talking about with respect to the chemical constituents, as well as the way that people are using it and the duration. So we know that the chemicals can have very different effects, and we're still learning about the potential outcomes. So I think that we're still unsure there with respect to understanding how it might fit in that model.
I'll just add that, one thought that's relevant to that bidirectional relationship is one who starts out by using, say, cannabis to manage their pain, or who has been using cannabis but increasingly uses it in relation to their pain, but don't necessarily fit the criteria for a substance-related disorder, might, via those continuous pairings, go down a path that could lead to cannabis as a substance-related disorder. So I think that's one applicable risk in that context.
And one thing, Joe, that you pointed out was hyperalgesia induced by using these substances. And at this point, we actually know very little about cannabinoid-induced hyperalgesia, specifically THC, because we think that THC is probably the primary component of the cannabis plant that produces their analgesic effects. And so, looking to see if, hyperalgesia is one of the constellation of withdrawal symptoms that might occur will also, I think, help to elucidate how hyperalgesia might contribute to increasing frequency of cannabis use, increasing the need for higher doses, specifically of THC, and going down towards developing some of the symptoms related to cannabis use disorder that go beyond just what you might see with therapeutic use, which might be, tolerance and withdrawal, but some of those other symptoms that are marked with more moderate and severe use disorders.
Yeah, these relationships are very complicated. I think you both did, and a lot of the presenters did a really nice job trying to tease out or demonstrate some of the complicated pathways. Is it a treatment? Is it a motivator? Right? Yes, and yes, and yes. Okay, a bunch of questions in the chat. Are there any data that suggest a correlation between kratom use and medical or dental health insurance coverage? Oh, that's interesting. So I think that question is getting at, are people reaching for kratom when they don't have prescription drug access? Maybe, is that the question?
I don't know. I'm not sure. I'm just learning about kratom. My area of expertise is cannabis and cannabinoids. And it seems like that's true in the cannabis space. and it might be true in the kratom space. There might be data out there, but it is definitely an important point to investigate. We did a study during COVID looking to see, motivations for cannabis use, for medical cannabis use, and how it might have been related to reduced access to healthcare and prescription medications that people usually received before, the COVID lockdown period. And there was a shift in cannabis use due to that. So there might be parallels there with kratom.
I think there's a lot to learn about kratom, it sounds like. Somebody asked a question about GLP-1s. Is there consideration being given to GLP-1s and their potential use for SUD and chronic pain? I've seen life-changing and almost unimaginable changes in craving for alcohol and cannabis use since taking tirzepatide.
It seems like this is definitely an area that people are interested in.
Yeah.
I mean, definitely for substance use disorder, I haven't seen that much with chronic pain. But if we haven't already seen publications out there looking at, people who are taking these medications and also have chronic pain to look at, reductions in chronic pain, they're probably right around the corner, I would guess. I don't know, Joe, do you know?
No, but there's little hints on both directions that make that question one that's potentially important. The addictive potential of those medications may not be as high. They might be. So there's just a lot we don't know. But I don't think that they just yet fall into the commonly used and abused category. So while it may have utility in one or both, it may not have the same addiction relevance as some of the substances we're talking about, but we don't know that it has none either.
Yeah.
Another important point is like thinking about how these different medications and drugs are being used with respect to access, frequency of use, so on and so forth, and their how that fits into their misuse liability, right? So, so ketamine intravenous or IM ketamine that somebody's getting in a medical suite is very different than the take-home medication that you can take, orally. Or for example, cannabis, which you can take, several times during the day. You think with the GLP drugs, if they're not necessarily available in that way or taken in that way, they might have also, reduced risk for the same type of misuse liability as these other three drugs.
And Ziva, I'm not sure if you can fully address this, but it seems like ketamine is easier to get than many medications that are not FDA approved, right? And require a lot of hurdles and prior authorizations, et cetera, to get funded. So do you have any sense of why the use is permitted outside of prescriptions to pharmacies?
I'm not 100% sure why there's a permission of off-label use in the compounding pharmacies for indications for which the way that they're being compounded, there isn't an FDA-approved indication. It's a very different ball of wax than cannabis, of course. I don't know. I do know that in Los Angeles, there's a lot of ketamine clinics. And there's easy access to them.
Interesting. One of the topics, Joe, that you talked about a lot was pain as a motivator for use of alcohol, tobacco. We could also add cannabis, ketamine. And personally, I haven't seen a lot of studies of treating AUD specifically in the context of people with chronic pain, treating tobacco use specifically in the context of people with chronic pain. So I guess I'm curious, from both of you, your take on that avenue of research. Should that be a priority?
My biased opinion is going to be a strong yes, but the reasoning lies in some of the why of what people are doing in this space. And I find it interesting too that while some are readily able to identify that, others may not be as aware of the role that their pain is playing in motivating or perpetuating their substance use. So I'm a big believer in psychoeducation and some of the discrepancy that Dr. Bakshai was talking about earlier, where many people who have pain, their primary goal is to reduce that pain or to improve their functioning. And if they can come to understand how substance use may be playing a role, working against their goals, and they truly come to believe the risk of that, right? Like health belief stuff, then their motivation for reducing or stopping that use, I believe, would increase, even if it wasn't there before, right? They may have had no problem with their substance use as it was, even if we might classify it as problematic. But once they come to find that it might be contributing to their pain, I think it rises up the priority list. And there's a lot of important space there to do educational intervention work, not even just in isolation, but even before undergoing a substance-related treatment, or as a way to increase motivation to engage such treatments.
Yeah,
Yeah, and I agree. Yeah, sorry. I was going to say that, I think that patient education is so critical for the patient and improving outcomes. If they don't understand the risks associated with taking multiple doses more than prescribed, or increased frequency of use, or increasing the dose, right? The actual dose that they're using, they might not be aware of how it can work against what their end goal might be. So I continue to be surprised that, people who I talk to who might be prescribed opioids or even using cannabis, they don't necessarily, they're not aware of the potential negative impact of using with increased frequency or higher and higher doses.
Yeah, absolutely. That's helpful. We have a question from Jafar. Currently, there's ambiguity about whether risky cannabis use should be included in intervention studies addressing all substance use conditions. Given the current evidence, do you think risky cannabis use should still be included within the substance use bundle? If so, should it use the same benchmark cutoff as other substances, or should it have a different cutoff? So that's about the classification of risky cannabis use.
So if I can help with it, because I think I didn't do a good job in explaining. So when I submitted my grant, like it was like chronic pain, orthopedic condition, like upper extremity chronic pain, and I'm addressing all substance users using one single intervention. And they obviously raised the question, okay, cannabis is legal now, and what's the cutoff for risky substance use? I'm using WHO assist, and the cutoff for cannabis is similar to tobacco and everything. So, and
I think that's helpful, Jafar. And I think we can broaden that to, how do we classify cannabis use, types of cannabis use, and risky. Even there are some issues sometimes with classifying as cannabis use disorder in the context of people using it therapeutically. Oh, our time is up.
Yes.
All right, so we'll just say it's complicated and we'll move on to Betsy.
Yes, and please feel free to respond to that in the chat. That's a great question. All right, thank you very much. All right, I have the task of closing us out here. So, oops, can folks see? I'm sorry, hang on. Let me stop sharing and reshare. All right. Can folks see my slides?
Yep.
Yeah. Okay. I have no disclosures. So my task is to summarize quickly what I think I heard today. And I think I put this into two broad categories. One is sort of overarching priorities, and then another is more specific priorities, which could also include those overarching priorities depending on the direction we want to take this. And we want you to react to this. Feel free to tell us what you think. I'll include the email address at the end, and I think Jackie also put it in the chat. So health equity has to do with everything we discussed today, and so I wanted to say that first. And the relevant approaches that were described are in some ways to get better data, but we still need to act now. And the suggestion to involve health equity experts in studies, I think, is an important one. But the data approaches that were described are potentially mandating specific data elements around social determinants of health, and consideration of a variety of study designs, including, I love this Framingham study of pain. We heard a great presentation about a target trial today, and qualitative work, and thinking carefully about outcomes, including equitable access and patient-centered outcomes, and avoiding exclusions that reinforce disparities. I'll note that there is an entire subcommittee on equity, but I present this as kind of what I think this committee's and this discussion's take on equity is. Importance of employing community-engaged approaches. And then we had a beautiful Venn diagram that Dr. Krunke put up earlier about pain and substance use, I think has been expanded during the rest of the discussion today to polysubstance use, mental health conditions, stigma, and potentially also other intersecting identities that people hold. These things are inextricably intertwined. And what we need is whole person treatment where we don't focus on one problem to the exclusion of others, but one may have to prioritize a particular problem for the purposes of a particular research study. We want to ask questions that can ideally inform policy, including implementation, research, leverage existing HAIL networks, and study treatment and prevention. Okay, so specific programs of research, disproportionately impacted populations. So we need to know who's being impacted by chronic pain and substance use and how. We can't address what we don't know. So these are the groups and conditions that were either mentioned or have been mentioned in prior subcommittee meetings. I added a few. I would add that people disproportionately impacted by pain and substance use are also disproportionately impacted by opioid prescribing, as we saw in one of our presentations today. And so some relevant approaches there may be deprescribing, multimodal care, and consideration of switching to buprenorphine, or maybe initiation of buprenorphine, which wasn't discussed, but is a thought. Expand research on personalized approaches. This also seems to actually be something that's overarching and should apply to everything from the discussion we've had today with regards to prediction and prevention and treatment. There were some great suggestions about mechanistic studies, specific phenotyping approaches, and looking at the biological, psychological, and social phenotypes, and EMA. And then exploring treatment with substances that have addiction potential in this last set of talks here, and some discussion of just needing more data on who's using them and how, and clinical trials of efficacy, and then supporting research on this should say non-pharmacologic treatments for both treatment and prevention, particularly at this intersection where there's very little. As we heard, there are a lot of things that work for at least one or the other. We should maybe be looking at implementation trials here. So please reach out if you have thoughts or suggestions on the topics discussed today, and send them to this email address. We need folks to respond as soon as they can. Actually, I think this date might be incorrect. It might be quite a bit sooner. I think actually by the end of the week, so we can incorporate into to what we need to present to the NIH. And I just want to thank everybody for being part of this whirlwind day. It's been a blast for me, and I think many others. So just grateful to have everybody here. So thank you all so much.
Great. Thank you, everybody. That was so informative and a lot to distill, and we will get to those research priorities. Thank you all.
Thanks all.
Thank you.
And for the presenters and subcommittee members, I believe we are migrating to a different link, correct?
Correct. Yes. Sophie is over there. Yes.
Okay, so we're gonna, for our wrap-up meeting that's gonna occur for the next hour, we'll go over to the other Zoom link, which is in your, should be on your calendar invite. We'll see you over there.